to for discussion. So this is the respiratory tract pathology. So we, as you saw on the outline, so we have just a brief introduction, then we discuss the upper respiratory system, nasopharynx, larynx, and then we go to the lungs themselves. So start with pulmonary infections, chronic obstructive pulmonary diseases, restrictive diseases, pulmonary hypertension, respiratory distress syndromes, lung cancer, and then we end with pleural. So as it was with other chapters, we cannot cover everything. So we just I selected the diseases which are more common. And but also I followed the book I sent to you. So we will more or less use the text is from there. So the things I have added, many there are pictures and the diagrams to explain things. So I have tried to make sure the presentation is as comprehensive as possible and well made. So covering things, molecular things, clinical things, radiological things, because dealing with lungs, that you cannot escape imaging. And also, I added one disease which was not discussed in the book, which is the COVID-19, because it is an emerging disease, so it is not yet found in the books. So in articles, yes, but in books, not yet. So, and I think as medical students, you need to know about it more deeply, not just the information you get from newspapers or media, but a scientific information. So the book, the first one, which is the main source of the text I have used, but pictures and the diagrams coming from different sources. So as the introduction, so of course we will talk more about histology and then physiology here, but I not read many things. And you know that for the upper respiratory tract system, especially the trachea, then the oropharynx, the larynx, the main okay, so I missed the things. So for the nasal cavity, the first part of the nasal cavity is lined by squamous epithelium, and then the second part, the inner part of the nasal cavity, is lined by the respiratory epithelium. When we say respiratory epithelium, as you saw in histology, we refer to the pseudostratified columnar epithelium ciliated with some goblet cells, which secrete mucus. And this lines the second part of the nasal cavity, and then from trachea until the bronchioles, you can say so. And then the first part of the nasal cavity, as I said, is squamous, stratified squamous epithelium, and this is the same for the larynx, where you have vocal cords, and the oropharynx. So they're aligned by squamous epithelium. So we have here a section of the bronchus. In the bronchus, we have a cartilage, and this is the same for the cartilage. Kandi bifasha mu gutuma habaho aho ubona trachea and bronchi zishobora kuba distended cyangwa se zikora muvoma they are mobile because they have muscles but also this cartilage instead of having bones. So iyo ari Imana irama agashyiramo bones byari kuba ikibazo, kandi nanone iyo hatamo ikintu gikomeye nka cartilage zari kujya ziba bent cyangwa se zikangirizwa n'ibintu. So Imana izi mpamvu yabiremye gutya, so we describe just what we are given. So going down to so we are talking about the nasal cavity, then pharynx, larynx, then trachea and bronchi. You know that the bronchi, we have the primary one or main ones, then it's the secondary ones here, the tertiary ones, Then the bronchioles, which are small, and the terminal bronchioles, which are the smallest. Not the smallest will be respiratory bronchiole. After which we have now alveolar duct, which branches into alveoli, and all these alveoli all together, they make an alveolar sac. And the histology is presented here. This is a bronchus. Now smaller bronchioles. Here you see that they are very close to the alveoli. So alveoli, you see that they are empty inside. This is the lumen. So this must be empty or clear so that the air can enter there, and then the exchange between it and the blood stream, the blood coming from the right heart, needing to get more oxygen, will be here in the small vessels, capillaries here, so that the air exchange, so oxygen and the carbon dioxide from this blood can be exchanged. And here you have a series, pneumocyte type 1 and the pneumocyte type 2, which it produces surfactant. So surfactant ni ituma izi alveoli zikomeza gufunguka kuri. Kuko igihe umuntu akoze asohoye umwuka, expiration, cyavuga ko ni nko kwakura umwuka mu gashashi gahita gahombana. So nazo zagahombana, ariko kubera surfactant irimo zikomeza kuba zifunguye, otherwise zirafungana. Aha ni naho duhera turibone indwara zimwe na zimwe zibaho aho alveoli ziba collapsed cyangwa guhombana, bityo umwuka ntujye ugerayo. So gas exchange between blood and the air will not take place in this segment. So that's in general the histology and the functions, of course. Mu kuvuga histology ni conducting, we have a conducting portion of in this system, kuva kuri nasal cavity kuzagera kuri za bronchioles. Then you have a respiratory portion, ahabera gas exchange hano kuri alveoli. So, and here we understand the main functions of the lungs. Of course, there are many other additional functions, nk'uko twabonye ushize, hari nka za serotonin n'izindi metabolites ziba metabolized by the lungs and to protect us. So the first disease from the nasopharynx is rhinitis. Umuntu avuga ngo afite ibicurane ariko ntabwo ari flu, no kuba gusa hari runny nose. Umuntu afite runny nose, so sneezing, congestion, it doesn't mean flu. Flu is usually caused by viruses, although they are the same. Ariko muzi ko hari itandukaniro, umuntu ufite rhinitis aba afite imbaraga, ariko ize flu kubera viruses acika intege cyane, ku buryo ahubwo kuruhuka bimubera nk'umuti, mu gihe ufite rhinitis cyangwa utundi tuntu nk'utwo we ahubwo akizwa no gukora nka siporo n'ibindi. So harimo nuance, harimo differences. So allergic rhinitis, we understand that it is caused by sensitization, hypersensitivity reaction type 1. So there will be neutrophils, of course, in difference to the flu, viral flu, in which we have lymphocytes, because viral infection is associated with inflammatory lymphocytic inflammatory cells, while allergic and parasitic ones are associated with eosinophils. And there are people who used to have a chronic rhinitis, so always sneezing, especially if there is a change in the weather. So klima yahinduka gatoya agatangira agasneezinga, akitsamura, akagira rhinitis. So this is allergic. Cyangwa se yagira ahantu hari indabo akabigira. So bigaragara cyane cyane umuntu wo mu bihugu Nordic countries such as Sweden and so on. Iyo hakonje, mu gihe cy'ubukonje bagira ikibazo. Ariko ibibazo by'abantu bari allergic biba cyane cyane mu gihe cy'izuba, kubera ko ubukonje ashobora kwifubika neza and so on. Ariko iyo izuba ritangiye kuza mu kwezi kwa kane, hahita habaho ko n'ibiti bitangira kugira indabo, so bakagira allergy kuri pollen. Nicyo kibazo bakunda kugira, then bazasufura mu gihe cy'izuba, mu gihe abandi bose baba bishimye mu gihe cy'izuba. So nasal polyp, I think you remember the shapes of the polyps here, as we saw it for the colon. So tunukose lukwa protrusion inside a lumen of an organ cyangwa se kuri surface of the skin, for example. Zirangwa n'utubyimba ariko turangwa nuko kaba gafite a small stalk, n'akantu gato akagozi kayifatisha ku mubiri, ariko akabyimba ko kaba kanini. So that is polyp. I think there are different types. Hariyo bita sessile, yo ibifite akagozi kayifatisha ku mubiri cyangwa kuri organ, ntabwo kaba aragaze bari kinini, so ni sessile, which is not in this case. So nasal polyp rero muzazibona kenshi, abarwayi ni benshi bazigira, ariko principe iri aha ngaha kugira ngo ubashe kumenya kuzitandukanya, hano ntabwo tubivugaho cyane. Hari iziri allergic, ziza ku abantu bagira allergic. So iziri allergic ziba ziri bilateral, no kuva in both noses, usually, not always, but usually they are in both nostrils. So when you see someone having a bilateral polyps, usually the main reason will be allergy. Ariko no one afite polyp, so be very careful. It may be a tumor, a benign or a malignant tumor. So niyo ni principe mugomba kugenderaho rero. Nuba n'umurwayi afite polyp, mwabaza what is most likely, ukavuga ngo allergic, bizaba ari ikibazo. Nizo zakuru nkunda kubabwira zibafasha kuba at least to be conversant with most common things. Ibirireya ukaba wabiyoberwa ntibe ikibazo gikomeye, ariko ibintu biri common kubiyoberwa bikaba ikibazo. So bilateral nasal polyps usually allergic and or inflammatory, inflammatory polyps. So on histology, we usually find eosinophils, many eosinophils, some plasma cells, edema because of the inflammation, and the eosinophils referring to the allergy. While other polyps, usually they are tumors. They are tumors. So angiofibroma, I personally have not seen a case, ariko this is one of the most dangerous diseases. So it affects usually young adolescent males, abasore batoya around your age, your class. So ni tumor iza muri nose, nasopharynx, so nukuvuga inyuma ya nose ahagana hasi muri pharynx, ariko ikiranga nuko it is very vascularized. And it is very bleeding. So impamvu tutayibona kenshi nuko once a clinician thinks about it, a clinician is not allowed to take biopsy. There is no surgical procedure allowed to do on a case you think it is angiofibroma, because it bleeds. If you do a biopsy or you do surgery on it, like incision biopsy, yeah, it will bleed and the patient may die just because of that surgery. So if you intend to do surgery, you must make sure you excise it completely. If not, don't attempt that. And this is the reason why this disease, although it is a benign tumor, is angio means vessel fibroma. So it is a benign tumor arising from the fibrous tissue of vessels. So it is just benign, but very hemorrhagic. So it is usually treated as a cancer. So where I have been, I saw that these cases are sent to oncology programs. So they receive radiotherapy, bakagashiririza, then you can do surgery afterwards. So whenever you think angiofibroma, don't attempt to do any surgical procedure on it. So nasopharyngeal carcinoma, this is a common cancer. In here in Rwanda, we see them. In East Africa, they are common. So it is associated with Epstein-Barr virus. So it is this virus is associated with lymphomas such as bucket lymphoma, but also some carcinomas. The most known one is the nasopharyngeal carcinoma. So you see its location, the location of the nasopharynx. You see this is the oral cavity here, nasal cavity. So it is just like a a bit above the junction of the oral cavity and nasal cavity. So above oropharynx is why we have a nasopharynx. So these carcinomas, of course, there are in many subtypes, but the poorly differentiated squamous cell carcinoma is associated with EBV. Ariko biranavugwa ko abantu bakunda kurya amafi yokeje cyangwa ashiririjwe, ibyo nabyo ni risk factor. So there is no, I don't know how to connect to that, but it was seen, especially abantu barya amafi arimo umunyu mwinshi nk'abava mu nyanja y'Ubuhinde kuko irimo umunyu mwinshi and so on. So they have to be very careful. And this is a deadly cancer because abatugeraho cyane nk'abo tubona sashika benshi aza afite cervical lymph nodes. So ugakora nka FNA check lymphoma cyangwa tuberculosis, ariko iyo hari information ko afite nasopharyngeal mass, it will be easy. So ikibazo kimwe nuko nasopharynx, it is also rich in lymphocytes, ko harimo za zira tonsils ziri hafi yaho muri pharynx. So on a cytology, it is not easy to distinguish this poorly differentiated carcinoma from this nasopharyngeal carcinoma. And even on biopsy, sometimes we do further tests to confirm if the cells we are seeing are epithelial cells or are lymphocytes. Ibyo ni ukubera ko mu kubavura muri oncology ntabwo carcinoma na lymphoma babivura kimwe. So that's why we always have to precise which cell has caused that cancer. So the risk factors are listed here: Epstein-Barr virus, nitrosamine, murayibuka twayibonye muri bintu bitera kanseri z'igifu, kandi nitrosamine uretse kuba muri smoked food, especially smoked animal food, inagaragara muri za preservatives bashyira mu biribwa bijya bibikwa mu supermarkets and so on. You have a smoke and the dust, and you have a poor oral health. So that's all for the nasopharynx. So for the larynx, we have, of course, I hope you remember the anatomy. So we have the oral cavity, then we have the epiglottis and the vocal cords, or this part is the larynx. Then from larynx, we go to the trachea. So one of the common inflammations is epiglottitis. Or epiglottitis or epiglottis. So it depends on the English you are using, American or the British one. The inflammation is usually caused by Haemophilus influenzae, but it can be caused by other things, especially in children who are not immunized. So muziko Haemophilus influenzae basigaye bayikingira mu Rwanda, ntabwo byatangiye kera nubwo mwebwe na mwayikingiye muri abana, ariko itangiye vuba, nkeka ko nta myaka 10 irashira batangiye ishyizwe muri national program. Ariko nubwo bikorwa, this bacteria has a lot of serotypes. So hari zimwe dukingira mu Rwanda cyangwa no mu bindi bihugu, ariko hari many other serotypes which are not vaccinated. So therefore ntabwo bitangaje ko umwana wakingiye n'undi akunda kugira izi zangine wenda dukomeza kuziga. So children will present with fever, sore throat, angine, dysphagia, kumira byange, muffled voice, ijwi rye rigahinduka gasarara, respiratory, stridor, kwinjiza umwuka, yawinjiza ukumva ari nk'ikintu kimuniga, akamera nka kundi byo kugona. Risk or airway obstruction. So when it is too much inflamed, ishobora kufungana umwuka kwinjiza bikagona. And of course, you understand that it can be life-threatening, while it is just, I can say, a trivial inflammation. And you see here, if you do like a cross-section from the epiglottis in a normal person, how the vocal cords are and the epiglottis, and here you see how the epiglottis has swollen, and it is of course compressing or displacing the vocal cords themselves. And this may explain why the voice will change. And also the narrowed airway, as we are saying. So the children with epiglottis will often sit upright with the neck and the head extended forward. So muri mu buvuzi twibyo bita antalgic position, umurwayi wese aragira akaba hari ikintu bitewe n'uko arwaye hari ukuntu yabonye ko kwicara mu buryo runaka cyangwa kuryama mu buryo runaka cyangwa guhina ukuboko cyangwa ukuguru mu buryo runaka bimworohereza uburibwe, so bita position anterior. So there is a laryngotracheobronchitis. So it means there is a inflammation of the larynx, trachea, and the bronchi. So you understand that it is a more extended inflammation as compared to the epiglottitis and the other inflammations you have seen. So usually caused by parainfluenza virus, and it presents with a voice hoarseness. Of course, because the vocal cords in the larynx will be affected. Barking, cough, and inspiratory stridor. So barking, cough, so a corora. So barking bakunda guheshwa ku nyamaswa niba ari nk'imoka cyangwa iki. So abakorora cyane ku buryo bukomeye asakuza. So this diagram is showing where is the problem. So the normal larynx and then the inflamed larynx, for example, but this inflammation doesn't affect only the larynx, it affects also trachea and the bronchitis. So it is usually called the croup. So here there are diagrams showing what happens. So you see that because of the swelling of the mucosa in the trachea, the airway is narrowed, and this can explain why there is a stridor, especially when at the inspiration, and it may even obstruct completely there and be life threatening. So ushobora gusanga umwana bamushyizemo na tube intubation, kubashyiramo tibe inyuze mu kanwa ikajya kugira ngo umwuka ushobore kugera mu bihaha ikagera muri bronchi, muri trachea. So ibyo birashoboka kubikora muri just inflammation like this, not a very severe disease. Because if you don't do that, then you will lose that patient. So you do it, and of course you treat the cause of inflammation, and you make sure the swelling is resolved, giving adequate drugs and so on. So in a few hours, you remove the tube. So the vocal cord nodule or singer's nodule, you understand, it is a nodule that arises from the two vocal cords, and usually bilateral as it is shown here on both of these vocal cords. So usually it is composed of degenerative tissue. Here, you have the degenerative, no kuvuga ko niba hari fibers nazo tukibona ubona riri fide ariko ntabwo riri fide. We storage ahubwo harimo fluid amazi. So we call it myxoid background. So bikunda no kugaragara ku muntu akoresheje ijwi cyane, and the treatment nta yindi ni just to rest, to make sure the voice is in resting condition. So bibaho ndanga n'umuntu bakorana bahanga ku bitaro wari umeze gutya baramubwira gutana nubwo twari mu kazi kasabaga ko abahari kuri task twari twahawe, ariko baramwinjije mu batahe iminsi 3 ajya ahantu atavuga nawo mu rugo ajya bandikira kuri telefone isohona ariko yirinda kuvuga. So nukuvuga ko icyo gihe inflammation ni fluid bizavamo, then abyimbuke noneho ijwi rigaruka. And bahita singers kubera ko aribo abaririmbyi bakoresha amajwi cyane. So birumvikana umuntu utasanzwe aririmba kuba yamara umwanya aririmba cyangwa se aririmba to ijwi ryo hejuru, akaba yarimbaga bass akarimba tenor and so on, bishobora kumugiraho ibibazo nk'ibi. So the remedy will be to rest. So laryngeal papilloma. So papilloma, and the way it presents itself, it looks like a polyp, but irregular, a polyp with irregular surface. So bikunda kugaragara ahantu hatandukanye no ku ruhu hari abo tugira bazigira. But the difference, as I said, the papilloma is a kind of a polyp. But in papilloma, the polyp here is irregular, and you can see here on histology why it is regular. Kubera ko mu gihe polyp ifite smooth surface, ahangaha ho it has branches like those of leaves or cauliflower. So these around they are squamous cell epithelial cells, and then inside we have a vascular core, in which of course the blood will come so that these cells they find nutrients through diffusion. So it may present with hoarseness of the voice. Wakora when the laryngoscopy, it is a tumor. Of course, the papilloma is a tumor, but it's not a cancer. But there are other cancers, as we shall see, cancers which can have a distal detector. So only histology will confirm if that is benign or it is a cancer or it is in between. When there was a papilloma in which we have some dysplastic changes, then it indicates that if nothing is done, then the cancer will come. So in that case, they do excision. So these are very common also in our context. We see them most of the time. So the main cause is the HPV, human papilloma virus, and this word you understand papilloma and papilloma virus. That usually where there is HPV, there is a papilloma when it is benign. If it is not benign, then a cancer. So the serotypes here are 6 and 11. So maybe you have seen that in virology or in other courses. So we have more than 100 serotypes of human papilloma virus. And these serotypes, some are called low risk. Low risk serotypes, they're the ones not causing cancer. High risk, they are the one causing a cancer, like squamous cell carcinoma in the cervix, in the oropharynx, and so on. So type 11, serotype 6 and 11 are known to be, they are the most common low risk HPV serotypes. While 18, 16, 52, 58, they are the most common high risk serotypes of HPV. So it is important ntabwo ari ukuvuga ko iyo umuntu umubonyemo HPV yabihagize ugomba kumenya ni low risk cyangwa high risk kugira ngo umenye uko umwitaho cyane cyane nk'iyo ziri muri cervix. So iyi 6 na 11 niyo ziri after cervix, ano, genital areas, penis, and so on. Also they will cause papillomas then. Izo zikunze kugaragara muri ano genital area, kirakura cyane tugita condyloma acuminatum. So kiba ari kinini cyane. When you see it, you think it is just a cancer because of how it looks like. So then to end this part, this larynx part with carcinoma, usually it is the squamous cell carcinoma because the larynx is lined by squamous cell epithelium. You have an introduction and each part, what is the lining epithelium type. So the risk factors are alcohol and tobacco smoking. And sometimes, if there is a laryngeal papilloma, it may progress to carcinoma. Ariko ibyo bivuga ko niba yari yatewe na low risk HPV, nuko hazaza na high risk HPV, if not controlled, then bikamutera kuba yagiramo na carcinoma. Ntabwo ari ukuvuga ko ya low risk serotype y'ubwayo izatera carcinoma. So there will be an additional HPV serotype which is high risk. So icyo navuga rero nuko izi ndwara ziriganje, ariko ziriganje na hano mu Rwanda, ariko sire larynx nivurwa muri ORL cyangwa ENT. Ariko icyo tubona nuko ziza zaratinze, abantu benshi bari muri advanced stage. Larynx yose bayikuramo ugasanga umuntu bamushyiriyeho akandi kanahumekeramo kari mu ijosi kuko umwuka nashobora kuzamukira hejuru. Ariko iyo ubabajije cyangwa urebye no muri files zabo, bo usanga ari umuntu wanyoye itabi igihe kinini, wanyoye inzoga igihe kinini, and so on. But tukiri ahangaha, wenda kuri oropharynx ntacyo twayivuzeho, ariko indwara zifata zijya gusa n'iza larynx, that's why. But in oropharynx, we have two types of carcinomas. Even muri larynx nabyo nuko, ariko pharynx niho bizwi cyane ku isi hose ko hari iziterwa n'itabi n'inzoga. That is one type. Hakaba n'iziterwa na HPV. So mu kuzivura bazivura completely different. So hari iyo bavuza chemotherapy, hakaba n'iyo bavuza radiotherapy. in addition to the surgery where it is possible. That's why it is very important to know. So ikindi rero nuko iziterwa na HPV byagaragaye ko bagira iyo bari kuri stage zimwe n'abafite squamous carcinoma yatewe n'itabi cyangwa inzoga, usanga abafite yatewe na HPV aribo bagira beta survival, so nibo bashobora kurama rimwe na rimwe bakanakira burundu, ariko yatewe n'inzoga n'itabi bo bagira poor prognosis. So ibyo ngira ngo murabyumvise. Better prognosis in HPV related laryngeal or pharyngeal squamous carcinoma compared to the carcinoma related to smoking and or alcohol. So baza rero byarabazaga barenze hano n'icyo kibazo gihari. So icyo navuga rero kuri iki cya kureba HPV, murumva ko ifite uruhare, it is very important to know if a carcinoma in a patient was related to HPV or not. So hari studies zirimo gukorwa. So iya mbere akozwe n'umwe our graduate, a postgraduate student, now she's working at the Butaro Hospital. So she did it in her master's degree dissertation. So twasanze muri squamous cell carcinoma for the larynx and the oropharynx 18% zose zari zirelated ku HPV. Bivuga ko uburyo bazivurwa bwagombye kuba budasa n'uko bavuye. So the recommendation was to do it routinely to all cases. Ariko ntabwo birashyirwa mu bikorwa because of many things, especially that antibody twakoresheje tureba ko bafite more HPV or not. It was just bought for the research purpose. It is not yet used routinely in our hospitals. But I think soon it will be done. So I know there is another lady now doing her PhD training, and she has now a project about this. So she will look not only at the immunohistochemistry, she will use now the genes to look at the genes if really HPV penetrated into them. Uko mubizi kugira ngo na HPV itere cancer nuko igice cyayo cha genome ya iyo virus cinjira muri genome y'umuntu mu maserire yaba infected. So if you in that case, then you can confirm that really this HPV entered the genome of the human genome and therefore triggered the cancer. Otherwise, kubona ko umuntu yagizemo HPV wenda yagarukiye muri cytoplasm, icyo ntabwo yaba yateye cancer. So then it means there's a molecular studies. Once we are done with that project, then we will have now a confirmation about what is the percentage of our patients who are having HPV-related laryngeal carcinoma. So these are vocal cords, the left one and the right one, and you see here that the carcinoma was just affecting the right vocal cord. So ngira ngo abarwayi ikibazo cyabo nyine yafashwe vocal cords, aba ntabwo ariko bashobora kuvuga, azamo na bleeding, guhumeka nabi, ku buryo akenshi azaba ahitamo intubation. So ikindi nuko urubikana niba mubaga ahangaha no mubaga bakabakuramo vocal cord, kuvuga bizaba ikibazo cyangwa ntibizashoboka. Ariko n'igihe arimo ya tibe kubera ko bahumekera mu ijosi, ntabwo ushobora kuvuga umwuka utanyura muri larynx. So kubera ko baba bafite akatibe gahita gahera muri trachea, bakoze bypass ya larynx ifite ikibazo, kigiyeho ntabwo avuga nubwo larynx baba batarayibaga, umushobora kubera ko umwuka ubunyura hasi yawe ntabwo ashobora kwirinda. So muzajya mubabona ku bitaro. So here we have another tumor here. See that it is now almost going to the left vocal cord region. So on histology, we see just squamous cell carcinoma. This is keratin. So when you have a tumor forming keratin, it is obvious it is a squamous cell carcinoma. So any questions so far before we proceed with the pulmonary infections? So I think we are done with the upper respiratory tract system. Now we go to the lungs. Any questions or comments?
Question.
Yes.
Here about ibyo ngibyo bari umaze kuvuga kano kanya. iyo tumor ihariho nta kintu bayikozeho cyangwa ngo ntibashireho iyo tube ho umuntu abasha kuvuga.
Birumvikana biterwa n'aho yafashe, kuko gufata larynx ishobora gufata ahantu ntifate kuri vocal cords, so icyo gihe ashobora kuvuga itarafashe vocal cords, cyangwa se yaba ifasheho zigishobora kumuvinga vocal cords akavuga wenda ijwi rigahinduka, ariko akavuga ati njyewe ijwi ryanjye ryarahindutse, yarananutse, so ni nabyo bimenyetso byagufasha kumenya aho ikibazo cye kiri utaranamusuzuma icyo gihe. Sinzi nawe ngisubije neza.
Yes.
Okay, thank you. Other questions? So I think those who will do ORL or ENT as a subspecialty will see many of these cases, or those who will do pathology. So akenshi hari naho mbona ubusanga yarafashe larynx, it perforates it, ikagenda ikagera no kuri thyroid, na thyroid ugasanga yarafashwe. So nuko abarwayi bacu baza bameze, unfortunately. So pulmonary infection, yes.
Yes, I want to ask about the papillomavirus.
Yes.
Because during gynecology and clinical chemistry, we see, in clinical skills, we saw that it mostly affected the genitalia part, but we have seen that also it can affect the upper respiratory parts.
Yes.
How it is infected?
How?
I was asking how it is communicated, how it is spread, how someone can acquire that virus.
Okay, thank you. So I think the way this disease transmits, first of all, this virus affects any squamous cell epithelium. That's the first thing. So anywhere there is a squamous cell epithelium, that cell epithelium can be infected. So hari naho tubona bayifite kuri skin, cyane cyane ku jisho hejuru kuri conjunctiva so twagiye tubabona, gusa benshi abayigira baba ari HIV positive, ariko bakaba bagize HPV bafite na HIV. So nabo abo abagira kanseri zo ku jisho zatewe na HPV. So ishobora gufata rero squamous epithelium yari yose, ntabwo ari nka Epstein-Barr virus ishobora gufata lymphocytes, B lymphocytes, ikanafata some epithelial cells in the oropharynx, ariko handi ntabwo ihinjira. So hari hose ishobora kwinjiramo, ariko the way of transmission it can be isuku nkeya bisanzwe, kuba umuntu ubwe yayiyanduza kubera isuku nkeya, ariko ntabwo twanakwibagirwa kuri contact navuzeho kuri herpes virus type 1, ubundi harizwi ko ari oral cavity, type 2 ikaba genital, ariko zikaba zaribanze kubera behaviors of people who do oral sex. So with oral sex, then it can be transmitted from the sex to the oral cavity, then proceed to the nasopharynx and the oropharynx and the larynx. Okay, any further questions? So no question, then you proceed. So for the infections of the lungs, there are so many, so we select just a few. So the first one is pneumonia. So normally iyi ngiyi niyo yitwa umusonga, yaba nk'umuntu arwaye umusonga ni pneumonia bashaka kuvuga. So pneumonia just means there is inflammation of the lung parenchyma. Ntabwo ari ukuvuga ngo byafashe bronchi, ntabwo ari ukuvuga ngo byafashe wenda trachea, ahubwo ni parenchyma, alveoli aho ziri around them. If there is inflammation, nazo ubwazo zigiramo ikibazo, of course. So, and the pneumonia is always caused by infection. Ntabwo ari inflammation iza gusa nk'uko aba ngo ni allergic, no, it is just by infection. And it occurs when normal defenses are impaired. For example, hari umuntu udashobora gukorora kubera uburwayi afite. Tubona bamubaze mu nda barasatura, nyine iyo bavuze mu nda barasatura, bahora bavuga ati nukorora kubera pressure uzongera muri abdomen bishobora guturika. So icyo gihe ntabwo byemewe. Cyangwa se ibindi bibazo byose byatuma umuntu atabasha gukora kubera imbaraga nke, arwaye umugongo cyane n'ibindi. Cyangwa yagize yaravunitse amagufa runaka nk'agatuza n'iki, ntabwo ashobora gukorora no guhumeka gake gake kugira ngo adatoneka. So ibyo byose bizatera ikibazo. Ikindi uretse ibyo by'inyuma, hari no kutagira cough reflex kubera impamvu zitandukanye. Nk'umuntu uri muri koma n'urugero, uri muri koma cough reflex wumva ko hari akantu kaguhanda mu muhogo cyangwa ukagerageza gukorora. Utabifite rero mucus, mu gihe tukora mucus yumvise yari imanutse ishaka kujya mu ngaho, we ntazabikora. So it will accumulate there, and wherever there is accumulation of the fluid, I think I told you this, wherever there is accumulation of the fluid or stagnation of the fluid, infection is very easy to come there. So whatever it can be, just retention of the urine. If urine is stagnant for a long time, so in the urinary bladder, ureter, and so on, infection will come in. So there are many other reasons here. So this patient, they present with fever because it is the inflammation infection, chills, kuriya basa no guhinda umushyitsi, ntabwo nibuka terme yabyo neza mu Kinyarwanda, ariko uyu muntu afite nka malaria ikaze ubona ari guhindagana atitira kubera, so nibyo bita chills. Productive cough ni ukuvuga arakorora ariko n'igikororwa kirimo, ntabwo ari dry cough. With yellow green sputum, which means there is a pus, it can be bloody, and we present with tachypnea, pleuritic chest pain, decreased breath sounds. So ni ukuvuga kuri percussion uzumva hari dullness. Ubundi iyo ukoze percussion yaba mwarabyize kuriya usa n'uhonda organe runaka, ubundi iyo harimo umwuka urabyumva ko havugiriza. Iyo umwuka utageramo neza harimo amazi n'ibindi, umva ko ari ikintu gikomeye, ikintu kitarangurura. So that is on auscultation, then ntabwo uzumva sounds kubera ko umwuka ntugeramo. Ubundi iyo umwuka uri kwinjira muri ziriya alveoli zigenda zaguka, ngo muzi hari utuntu bakunda kuza namo packages nk'iki, ubuze ikintu runaka yaba radio yaba iki, hari udushashi bashyiraho inyuma ariko dufitemo utuntu tumeze nk'uturi mu mwuka. So na alveoli ni physical. So igihe rero turi atuntu turi kwaguka twinjira mu mwuka, dusa uba wumva ko turi kwaguka, ukabyumva kuri auscultation. Iyo duturagurika nanone ni ikindi kibazo, ariko iyo wumva ko hari ibintu biri kwinjiramo nk'ibintu biri kwinjiza mu mufuka, ibyo bigaragaza ko umwuka uri kugeramo. Ariko iyo itageramo rero nta kintu, no sound. So that here there is decreased breath sounds. Of course, they have increased white blood cell counts because there is an infection. So on these diagrams, this is a normal alveoli, and you see here that in this alveoli we have a fluid and the pus filled, which have filled the air spaces. Ibi murumva ko bisobanura impamvu umwuka niba utageramo hano, niba ntugeramo kubera ibintu byuzuyemo, bityo bikanatuma kuri auscultation nta kintu wumva, bigatuma kuri percussion wumva nta bitirangira and so on. So ni bifatira ikintu gikomeye kumenya ko umuntu afite ikibazo muri pankayima, mu bihaha by'imbere hatageramo umwuka uhagije. And then when you combine with the clinical information, there was a fever, or sometimes then there is a productive cough, there is tachypnea, ibyo by'urabyirebera guhumeka vuba vuba, araribwa, then ibyo byakufasha kumenya ko umuntu afite umusoro. Birumvikana ni indwara ikunda gufata abana, cyane cyane ko abana n'ubundi wenda gukorora, yego barakorora ariko hari igihe mucus igenda, ntabwo wenda ko ntabwo igihe baragera, ntabwo ari kenshi bagira iyo reflex yo gukora ku buryo wenda aribo bibasirwa cyane. Ariko ikindi bafite immunity ikiri hasi ku buryo izi infection zibafata ku buryo bw'amabacteria za staphylococcus n'ibindi twese tuba tuzifite ariko ntizituganze ngo zitere uburwayi uretse igihe habaye ikibazo zikiyongera cyangwa se immunity yacu ikagabanuka. So pneumonia then has three patterns. Hariyo bita lobar pneumonia. Birumvikana ko bita lobar. Imwe akaba bronchopneumonia. Okay, ndasimbutse bronchopneumonia yo ifata lobule. This is a lobar pneumonia and this is a lobar. So nkanga murabona kuri X-ray, I hope you know to interpret this. So ahantu hari umukara cyane hano kuba kwarimo umwuka. So niba iki gihe rero gifirimo umwuka akiri umukara gutya nuko harimo umwuka ugeramo hose. Ariko iki ngiki cy'iburyo murabona ko ngo nabyo muzi kubireba. So kuri X-ray igice cy'iburyo kiza hano twita ibumoso bwawe. So ni nkaho umuntu ahagaze akureba. So this is the right side, this is the left side. Ikindi kigufasha kubireba nubwo baba batakubwiye naho umutima uri. So you see that the heart is more on this side, so therefore it is the left side. Uretse igihe umurwayi aba afite ababa bafite umutima wagiye ibumoso n'izi organe zose zaragiye zihinduranya ariko ni bake. So here then you see that the upper lobe here is not seen, is not having air in it. So it is afite consolidation. It became solid, solid, and that's why the air doesn't go inside there. So I think it is very easy to say there is a lobar pneumonia, or at least uzatangira ute hari consolidation or opacity. When you aheruka kujya tugita opacity. So there is opacity of the upper lobes of the right liver. So, and therefore, based on the contexts of fever and so on, you will confirm probably this is pneumonia because it can be another thing else. So it is easy then to see this lobar pneumonia, but for the interstitial one, so interstitial nuko ifata za alveoli zitandukanye ariko ntabona ko lobe yose yafashwe cyangwa ko lobire yose yafashwe. So igenda ifata akatu alveolar sac tumwe hano utundi hariya ku buryo kuri X-ray ubona ko ahantu harimo utuntu tweruruka. So for example, if you compare this left lung on the first picture and these lungs, they are different. These lungs, they are less black. Less black means there is less air as compared to this lung here. So it means then there is a consolidation or opacity somewhere, but it is affecting smaller structures which are not confluent. For the bronchopneumonia or lobar pneumonia, you see that now the affected zones are larger than in interstitial pneumonia, although not the whole lobe is shown to be affected completely, but you can see in all lobes, especially the lower lobe here, you see that it is affected in many, in most of its parts. So there are a few areas which have a. So I think as a maybe beginners, for it will be easy to identify this, probably not easy to identify these two. But at least from pneumonia, you can see that there is a problem. There is opacity in both lungs, which maybe you can fail to describe, but at least say that there are opacities. Maybe you can fail to know what is the disease. So I think then other things we take the zolsoma and especially the causes here. The most common cause is Streptococcus pneumoniae, indini Klebsiella pneumoniae, and nizo zikunze gutera lobar pneumonia. And you see the lung here. So ikibazo rero kibaho ni iki, ibihaha bigomba kuba bifite alveoli zinjamo umwuka, bityo ubundi niyo bifata ubona ko ari ikintu kidakomeye ugira ngo ni ibintu by'ishashara biri aho ngaho kubera ko imbere harimo utuntu tw'utubide twinshi. Ariko umuntu wagize lobar pneumonia kubera ko huzemo amazi gihinduka solid ku buryo batakubaje utazi aho bakuye nk'iki gice wagira ngo ni liver. So that's why there is this sign called red hepatization. So you see there is a word liver here. So the lungs they look like liver because the alveoli are no longer there. Everything is full of cells and so on. And on histology, you will find that the alveolar sac, so in alveoli, so they are surrounded by this septa, zirimo capillaries, zimwe zazanaga umwuka ugomba gusukurwa. Ariko you see that in the lumen we have things. So ari byo usanga ko umwuka ntushobora kugera ahangaha kubera ko huzuyemo ibindi bintu. So usanga huzuyemo dead tissue debris, harimo inflammatory cells na bacteria bigakora pus. So pus igizwe ubundi na dead tissue debris, inflammatory cells, and the infectious agent. So here we can say that there is a remnant here, one alveolus, otherwise all the other alveoli are full of these materials. So you need red hepatization when it is still red, and sometimes when these red blood cells kuba harimo na hemorrhage iyo zibaye destroyed, hazaho the other pigments, hemosiderin and others, then the color will change from red to gray. There was a harimo gray hepatization. And then after we give a treatment as a resolution, we have the scope of the bimeze ariko rimwe na rimwe hagumamo fibrosis ariko ntabwo ifata hose. So here we have the causes of rubber pneumonia, as we had mentioned this bacteria, and then the causes of bronchopneumonia. The most common is Staphylococcus aureus, while here the first one was Streptococcus pneumoniae. And hari ikintu nashaka kuvuga kuri Klebsiella pneumoniae irahari mu Rwanda, ariko ikibazo kimwe gikomeye nuko imiti ivura ari mike. So muzumva bavuga ibyo bita antibiotic resistance, resistance. Ngira ngo izanakomeza kwengera mu gihugu cyacu kubera uburyo imiti ifatwa usanga umuntu wese ashobora kujya antibiotique, farumasi ashobora kuyiguha na centre de santé n'ibitaro bikaba bitanarebye bacteria ufite. So icyo byara ni kireba ufashe amoxicillin wenda ntihomba kuyifata. Navuze ko dusanganywe bacteria muri twebwe nka za Staphylococcus, za Streptococcus. So izo bacteria dusanganywe zitaduteye uburwayi muri icyo gihe zizamenyera wa muti, uburyo nibyara indi bacteria izabyarwayo izaba ifite uburyo develop mechanism itazabashwa na wa muti. None wa muntu narwara indwara nyine zinatewe na ya bacteria ukamuha wa muti ntacyo bizatanga. So nicyo kibitera resistance. So icyo nabwo rero nka CHUK ndetse n'ibindi bitaro hano, Klebsiella pneumoniae is one of them. It is very difficult when you have a patient, cyane cyane abarwaye cyane wenda bamubaze mu mutwe cyangwa ahandi neurosurgery and so on, ugasanga none bakavuga bati yagize infection, nosocomial. It means infection acquired within the hospital or health center, health facility. Nosocomial infection muri laboratory bagasaba ati twasanze ari Klebsiella pneumoniae. So biba nkaho ijuru iguye kubera ko nta muti uzabona umuvura. So it is a very big challenge. So nkunda kuba abantu ni nk'igisasu abantu bicariye ahangaha ariko abantu batitaye kubera ko abakora kwa muganga especially teaching hospitals. So abakora muri this hospital iramunana kwivura akohereza, ariko iyo tugezeho tukabura umuti n'umwe mu miti ishoboka ihari izwi no ku isi ikomeye igezweho n'umwe umuvura, wakora iki? Ubuze umuti n'umwe uzashobora iyo bacteria, kuko murabizi muri microbiology mwarabyize, iyo babonye bacteria nk'iyi cyangwa any other bakora icyo bita antibiogram. Ni ukuvuga barayifata sample, ya sample babonyemo i bacteria bakayishyira muri culture media. Culture media yakozwe yakozwe mu nganda cyangwa ari nizo twikorera lokale, ishobora gutuma za bacteria zikura zikaba nyinshi. So uzikuza kubera iki? Kugira ngo ubashe gukonfirma ko ari koko, uko ushobora kubona ushobora kuba rereri yabaye, so ukabona ko ari zo koko ikindi noneho iyo zimaze gukura bo akenshi ntabwo ari zimaze gukura, iyo zimaze kuzihinga gutyo urambikamo ikinini, ariko ntabwo ari ibinini baha abarwayi, ahubwo niba ari icyamoxicilline ni ikindi kinini cyabugenewe gukora iyo test atari icyo kunywa, ukakirambika muri culture medium. none uko bagiteri zikura ukareba za bagiteri ziri zegereye cya kinini zirapfa cyangwa ntizipfa. So hari usanga rero zapfuye ndetse bikagera kure cyane, bigaragara ko uwo muntu numuha cya kinini cyangwa ya injection, kubera ko nyine tuba dufite ibinini ariko umuti ari ubwo bari injectable gusa, ukamenya ko ari sensitive. So icyo gihe laboratoire basubiza ati afite Klebsiella pneumoniae, twayipimye ku miti myinshi, wenda imipeneme, ceftriaxone, cefotaxime, amoxicilline, Bactrim, dusanga yose iri resistant, nta n'umwe ushobora kumuvura. Cyangwa bavuga ati ibiri muri yo twasanze iri sensitive, ni ukuvuga yica izo bagiteri, indi twasanze nta kikora. So icyo gihe umuganga amenya ngo ndamukura. So ikibazo rero kikaba igihe bagusubije ngo mu miti yose twapimye nta n'umwe ushobora kumuvura. So umwe mu njyabara n'abigisha microbiology twahoze twigana icyo bashaka gukora ubu ngubu ni ukujya bafata imiti imwe n'imwe bakayibika. Ni ukuvuga nk'ubu nibwira ko mu myaka ya 2010 gutyo nk'umuti wa Bactrim warakoreshwaga cyane muri infection, cyane cyane izi zifata n'aba HIV positive bose barayihabwaga ngo ibarinde kuzagira opportunistic infection. So nyuma habaho resistance ku buryo bukomeye, ku buryo umuramaga bagiteri ntiyica akantu na gatoya mu ndwara. So Bactrim barayihagarika bisa naho itakinyoma, ariko uko kuyihagarika bitanga benefit ko za bagiteri zose zari resistant kuri iyo ubu ntizikiri. Bivuga ko ubu ngubu umuntu ashobora kuwuhabwa ukamuvura. Ni nabyo yambwiraga ati nuko abamwe babihinyura, ariko aho kumuha ya miti igezweho ya imipeneme ariko muti wa antibiotic uriho ku isi yose uri hejuru kurusha iyindi, niba twasanze uri resistant twamwera ka Bactrim mu gasuzugurwa kuko ubu ngubu kari active kuri. Iyo niyo procedure niyo batangiye bashaka gukoresha, kubera ko nta wundi buryo buhari. Ni nko kubona umurwayi agwa mu mazi akarengerwa n'amazi umureba nta kintu ushobora kumukora. Kugira ngo ushobora kumva ko ari ibintu byoroshye, ariko nuko biba bimeze. Niba ufite umuntu afite infection udashobora kubonera umuti n'umwe wamubura, ni nko kubona umuntu asha umureba udashobora kumumwarura muri. So kuri twe niko tuba tubyumva. So then we have many projects which are being done. Hari ibyo bita antibiotic stewardship, ni ukuvuga nishyirwa mu bikorwa. So it is a project nishyirwa mu bikorwa, hazabaho amategeko akaze yo kurinda ko abantu bagira access to antibiotics ko biboneye. Ko mu Burayi cyangwa Amerika ntabwo ariko bimeze. Even in hari antibiotics twakoreshaga muri research byatse turi gutestinga ibintu runaka. So the way we handle them ni nkuko duhandoringa ibintu biri radioactive cyangwa ibintu biri carcinogenic. Ibirinzwe ku buryo bikomeye, nta kindi babikorera, ni ukugira ngo bazirinde ko bagira resistance. Hari ibihugu bajya bavuga birwana bikanarwana ibyo bita biowar cyangwa ibintu biowar wars, ni ukuvuga intambara ishingiye kuri biology. Ni ukuvuga akaba baza bagatera indwara nka bagiteri yandura cyane kandi yice cyane mu gihugu runaka, wenda bashobora gukora n'ibihugu bikomeye. So ni ukuvuga nk'ubu ngo hageze ikibaho bakajyana nka bagiteri ziri resistant ku miti yose bakazijyana mu gihugu runaka, icyo gifatwa nk'icyaha gikomeye, ni icyaha cy'intambara, kubera ko ububasha bw'intambara batazarwanira bashobore kuko nta miti. So I wanted to emphasize on that issue of antibiotic resistance. So when you will be prescribing these drugs, normally you should prescribe them if you have tested the patient is positive. Ariko hano mu Rwanda usanga abantu muzajya mwishimira na kuvura abasirimu, ako wenda mu private niho bahaza babazanira amafaranga n'ibiki byose akazajya muri private. Ariko ikibazo cyabo nuko baba bashaka influence. Umuntu azana umwana afite just rhinitis akaba ngiye mu antibiotic kandi ntabwo avuga ngo ngo mu antibiotics akobrira ngo mpe iyi ngiyi ikomeye cyane. Ubundi nawe kugira ngo umunezeze uzahora ubona abakiriya bavuga ngo hari umuganga mwiza bavura abana neza, then ukayimuha. But this is the end result will be that after some months or years, that drug will no longer be effective in treating diseases. Kwa kuyiha abantu batayikeneye, bagakereya resistance muri bo, za bagiteri we asanganywe muri we namuteye uburwayi, umunsi azazitransmittinga ku bandi, kubera ko we yamenyereye wa muti, babandi ntibazavurwa na wa muti. So this is the situation we are in. So pneumonia, the rubber one, ngira ngo twabivuzeho ni yindi ifata robire, so ifata utuzone duto, and here we have again hari uduce tumwe tumwe, we have red hepatization mu duce duto cyane, ariko ahandi you can you see these are the branches of bronchi and so on. So the interstitial pneumonia, as you say, it is sometimes called the atypical pneumonia. You see just ground grass. Ground grass ni kuvuga ahantu hasa naho hari ibirahuri bita ground grass, nicyo babyitiriye, bisa n'ibisharabitseho, unda gushyira ahantu kugira ngo habone, ariko kuyo umuntu uri hanze atabona imiryango iri mu imbere urabone hanze. So ukabibona ko hari utuntu twa opacities hirya no hino, ariko udashobora kuvuga ngo kari limited ahantu. So ngira ngo ahangaha kuba menye radiology nkanga hari air, hari umukara hano hasi, ahangaha ni ibumoso, so ni igifu. Uko iyo uhumeka umwuka ntabwo ujya mu nda gusa, arimo ujya mu gifu byo n'ibisanga. So mpamvu hano barimo air mu gifu, bifasha no kubona aho kiri. So ngira ngo ubundi kera habaho appareil photographique asanzwe atari uhaze digital cameras. Ubundi iyo bafotoraga umuntu hari ibyo bitaga negative. So negative ni uko yabaga imeze, ni ukuvuga aho ubona hano ari umukara na hari vide na hatari ikintu. Ahari umweru ahangaha niho hari ikintu kiri solid. So niba ugiye kogesha iyi foto iyi negative, hano hari umukara aho ugasohoka haba habaye umweru kuko nta kintu byo. Ahari umweru hakasohoka habaye irindi bara. So ngira ngo byo murabizi, habaga ari icyatsi kibisi hahindukaga umutuku iyo bozaga ifoto. So izi rozi ari za negative za congratulation. So the causes of interstitial pneumonia, the first one is mycoplasma pneumonia, you have a chlamydia pneumonia, respiratory syncytial virus, and so on. So this is what we can say. So pneumonia irahari umusonga, kandi ni indwara igaragara bituma abantu bajya mu baba hospital, kandi biranumvikana murebye ibintu biba byayiteye, pathophysiology yayo n'ukuntu y'ubwayo imeze, liver lung bitakibona umwuka, ikinjiramo umwuka. So ni indwara iri grave, ntabwo ari yo gufata mu buryo bwose. So there is a aspiration pneumonia. Aspiration ni ukuvuga akenshi ijambo rikoreshwa ku muntu kumwe umuntu arya ibintu agakorwa bikinjira muri digestive system. But what is worse ni igihe umuntu akoze vomiting, aho yango ibintu bisohoke hanze, bigwe hanze, ahubwo bigahita byinjira muri respiratory tract. Aribyo mubona nkangaha muri iki gishushanyo harimo ibintu by'icyatsi kibisi, ni ukuvuga ni bile. Umuntu akoze vomiting, then aho yango bisohoke hanze bihita byinjira muri larynx, then bimanuka mu gifu. So the consequences, as you see, bikunda gufata lobe yose. Lobe yose iba inflamed. Iyi acid ubwayo ni toxic, hari bacteria zizamukana nayo, hari parasite zishobora kuzamukana nayo, ibyo byose bitera ibibazo ahangaha. So ikintu uko bishobora gufunga bronchial branch zimwe na zimwe, noneho stagnation of the fluid inside there, the mucus produced there, bigatuma hazaho
salah disebut. Kore neza sha. Rero nuko irarangira atanga na quiz. Bena ko quiz nta no kuyitanga, ikibazo yakosoreye ku kibaho n'icyo makinga. Rero icyo menya n'abadakiri muri class.
Kiri byanze.
Rero icyo class ntabwo yirimo. Umukanya ngiye virus na
Okay, so welcome again. So I had got the internet interruption, but now I got it again. So we can proceed from where we are. So I hope you have taken the break as I told the class representative.
Yes.
Okay. So do you see the screen?
Yes.
Okay, thank you. So I was explaining the way people get can get this aspiration pneumonia. First, ni ibyo kugira ibyo bita force route, ibyo umuntu anyoye cyangwa ariye bikayoba. Birumvikana ibyo bishobora kuba ku bantu batandukanye. ariko ikibazo kirushaho gukomera ni abantu bagira vomiting, cyane cyane nk'abari alcoholic cyangwa bari muri koma cyangwa utwana dutoya, hanyuma aho kugira ngo bisohoke hanze bigahita bijya muri respiratory tract. So in addition to yo kuba hari obstruction of airways, ikindi cyongera nuko acide yo mu gifu igenda ikangiza ibihaha. Ikindi ni bacteria zizamuka umuntu asanga the normal flora we have in the gastrointestinal tract is not the same as in the respiratory tract. So bacteria nshasha, even the parasites from intestine in the duodenum, for example, which will go to the lungs, will cause problems including abscess. So, and I was explaining why this goes to the right lung. It is because it is explained here. The right main stem bronchus branches at a less acute angle than the left. Kwako ibumoso igihe kiba cyasunitswe n'umutima bituma bronchus yaho isa n'itambitse. Iburyo rero ibisa n'ihagaze neza. Kuyagaze neza bituma ikintu cyose kimanutse. Biroroshye ko kiboneza iburyo kurusha ko kijya ibumoso. Ibindi rero bigikunda gufata robe yo hasi kubera ko umuntu akunze kuba ahagaze cyangwa se yicaye cyangwa aryamye ariko asa n'uwiseguye, bityo bijya hari hasi hashoboka. So that's why you see it here. But I know cases where the upper lobe was affected, especially nk'abana bato bagine baba baryamye cyane batanaseguwe, bishobora kujya muri NRO. So mu gifaransa ibi ngibi twabyitaga Mendelssohn syndrome, kuba umuntu akoze vomiting ibyo ari agahita abikora inhalation, twabyitaga Mendelssohn syndrome. Question?
Yes, lecturer, I want to ask about when there is aspiration of vomiting materials without the bacteria inside can develop that pneumonia. If there is no bacteria contained in the food someone aspirates from the stomach.
I can say there is no bacteria in the stomach. It may be not there, but in the esophagus we have a normal flora bacteria and the other pathogens. They are there unless someone has a strong immunity. Ariko icyambere cyo nuko obstruction y'ubwayo acid igiyemo byabyo bitera inflammation. But usually it is accompanied by bacterial infection. So it is seen. So rero nta buryo kwaba nta bacteria ziri bujyemo kubera ko hari n'izishobora ku akenshi bibyiganira mu kanwa bikamanuka nyuma, hari n'iziva mu kanwa zikamanuka uretse n'izivuye muri esophagus. So bikamanuka kandi izo mutira mu kanwa ntabwo ari zo zagumye kaze muri hasi muri respiratory tract, I mean normal flora. And then because there will be obstruction, now they will be like zizaba zihishe immunity, ntabwo izaba zigeze ahantu immunity itazigeraho, mucus idashobora kuzizamura na za cilia ziri kuri epithelium ngo zizamure zizigarura inyuma kubera ko hari there is inflammation by the acid itself damaging the cilia, and also there is obstruction kuko iyo hinjemo ibintu nk'ibi these materials they will obstruct. So all these things they help even in those we consider normal flora bacteria to become pathogenic in that area because they will proliferate without control. Igitangaza nuko ahita agira iyi pneumonia mu masaha make ugasanga lobe yabaye gutya. It is what is amazing. Bihita bimera gutya, ntabwo ari ibintu bitinda. Ubundi umuntu yakumva ko byamara iminsi 2 cyangwa 3 tukabona kugira pneumonia neza gutya, ariko agira icyo kibazo ukamujyana kwa muganga bagakora ukakwita reanimation kuko umwuka utagenda, bamara wenda kuvanamo ibi ngibi imyanda yo muri bronchi gukora iyo aspiration n'ubundi isanzwe atari ukuvuga y'uburwayi bakabikuramo, ariko mu masaha make n'undi usanga yageze pneumonia. So I don't know how that is done just in a few hours to have such opacity like this. So going to COVID-19, as you know, COVID means the coronavirus disease 2019. So murabizi ngira ngo ni imwe mu ndwara zadutsemo muri and you were in the medical field, so you should know more about it. So igitera kubera ko bayivumbuye gutyo bahise bayita gutyo. So haba hatarakorwa ibintu byinshi exams ngo bamenye ni igiki yatewe na bacteria mu bwoko uretse kuba ngo ni coronavirus ubundi niyo mu buhe bwoko. So nyuma igihe gito basanze ari iyi virus, hari virus yigeze ibaho mbere yitwa severe acute respiratory syndrome coronavirus. So yari isanzwe. So ariko iyi yaje bitandukanye bituma ya indi ya mbere ubu banye kandi bashyiraho rimwe iyi adutse bakashyiraho kabiri. So basanze bamaze kubona ko ari mu bwoko nibwo cyo bavuga ngo virusi y'ubwa basaga n'ahise COVID-19. Noneho nyuma bati iri jambo rimaze kujya muri media cyane ntabwo twari turamo COVID-19. So baravuga bati COVID-19 ni uburwayi, SARS-CoV-2 noneho ni virus yitera. So nuko bahise babikora. So nyirango ni ibintu mugomba kumva nkawe. So sequencing n'ibindi byose structuring ya kwibona kuri electron microscope barabirebye. So hagaragaraho ibintu nka viruses zose ibifite stanocore, phospholipids and then na protein imbere na nucleic acid. You know that any virus has either DNA or RNA. So coronaviruses n'usanzwe zigira RNA ntabwo zigira DNA. Keretse ishaka ku rimwe na rimwe bita retro transcription kugira ngo ikore DNA kubera impamvu runaka kugira ngo ijye gukora replication for example, otherwise mu bihe bisanzwe ni RNA. So kugira ngo yinjire mu mubiri rero byagiye bitwara igihe muzi ko abantu bibazaga ni gute virusi yandurira he ni mu guhumeka byaje kumvikanwaho nyuma ariko mbere byari ikibazo. So byose mwagiye mubibona. So nyuma aravuga ati none se ni iki gituma bibasira some organs and not others. So nyuma byaje kugaragara ko as any other virus ntabwo ifa kwinjira mu mubiri wacu rimwe ku buryo butangaje nuko birayanditse ariko ibyo biranagaragara no mu buvuzi no muri biology urabibona. So ntabwo virus yapfa kwinjira muri cell any of our cell ahubwo igomba gukingurirwa. So there must be a receptor through which it will enter. So nyuma rero baje gusanga yinjira muri iyi receptor ya angiotensin conversion cyangwa converting enzyme type 2. Murayizi mwarabize muri physiology mu bindi bintu bya renin angiotensin ari nyirango n'imiti ya ibintu bya kidney adrenal glands pituitary glands bijyana mu regulation of sodium, for electrolytes, water and blood pressure. So byagaragaye ko iyo receptor niyo izi virusi zifataho zikashobora kwinjira muri cell and they enter into oral respiratory cells and respiratory cells. So either in the oral cavity or respiratory meaning nose and so on. So iyo imaze kwinjira bigenda bite nkuko bisanzwe virusi iyo yinjiye ihita ifatana na membrane cellular membrane. So kuko nayo ikozwe na phospholipids ni nuko. So imaze kwikora gutyo ibyo yari itwaye birinjira mu buryo bw'akavesiko none akavesiko. So here we have respiratory the virus enters the tissue, the cells. So here it has already penetrated the epithelium. So the vesicle here igezemo ikora kuko ibitwaye genetic material nayo isa naho ibiza ubwenge. Iyo genetic material igomba kuyigeza aho igomba kugera itangiritse igakora ubugome bwayo ishaka gukora. So ikikora nuko genetic material ihita iyijyana ahantu kuri vesicles dusanzwe dufite nka za ribosome and so on. So here they don't precise which one. So ikayijyanamo ariko iyijyanamo ikintu cya mbere ijyanamo harimo na protein sa kubera ko virus ibintu byose ikora kimwe n'amaseri yacu ntabwo ibikora ibintu byo mu kirere nk'ibyo twebwe abantu twita amagambo, ahubwo ikora amategeko yose atangwa na cell atangwa mu buryo bwa protein. So izi protein zayo rero nizo zigenda zikinjira muri serire y'umuntu, okay, host cell. So umuntu gusa nari n'inyamaswa zishobora gufatwa n'iyi virus. So there's protein now will make sure the RNA of this virus is taken care of and is allowed to replicate. And when it has replicated, it will make sure each genome it's packaged in its own vesicle. Ako ka vesicule gashasha ariko nimwitanye na vesicule dusanganywe niko kazaremamo indi virus. Iso mu byita virions muri virology nko mu byita. So izo virions hano ubwo nuko hano hinjiye virus imwe muri iyi epithelial cell, hano ubwo bagaragaza ko ari imisotsi ariko ntabwo ari, ziba ari billions and billions zitazisohoka, bityo niba umuntu yabaye infected by one coronavirus, hano zizasukamo ari nyinshi, they will infect other epithelial cells, noneho umuntu agende yongera the quantity of coronavirus afite muri we zikwirakwira hirya no hino. Ariko ikindi izi noneho ni nazo azabasha gutransmittinga ku wundi muntu. But tukiri aha ngaha rero, igihe zivuye muri epithelial cells zisohotse, izi nizo zinducinga our immune system. So hano nicyo dushaka kuvuga, no kuvuga ko imwe yinjiye ubwayo ntabwo twavuga ngo izahita itarafatwa muri epithelial cell, ntabwo izabasha kwinducinga our immune system to react. So aha ngaha bigenda bite rero, we have cells in immune cells. So the prototype here is the macrophage, which engulf. So epithelial cell kuba izaba yarwaye izatanga ibimenyetso ko yatewe. Nk'uko waba uyobora akagari agaterwa, then ugomba gutanga impuruza ko watewe, then these cells will come, the immune cells. By coming, this macrophage will engulf this virion or this virus. After ingesting it, murabizi muri immunology ko bigenda, then ikikora ntabwo yica gusa, irayica ariko bati nkuko waba uyobora ikigo cya gisirikare cyangwa ikibuga mugafata abanzi, rimwe nawe ntabwo mubafunga gusa, ahubwo hari igihe bamwe mu bafata mukaya kuberekana mu bataye bangwa beho ko hari abanzi bahari n'ibindi mujya mubona ko bikorwa. Ariko wenda ubu hariho human rights. Ubundi kera intambara zabagaho cyari zo dusoma mu mateka ya kera, abo bafataga barabica, ariko bakagira abo barokora bazababwira ngo wenda twakoraga gutya, twateye kubera impamvu n'ibindi. So aha ngaha rero nubwo virusi iba yishwe, ntabwo ibyari bigeze yose bishwanyagurika. Hari antigens zayivuyeho ziri specific, ni ukuvuga zitagirwa n'ikindi kintu kitari iyi coronavirus type. So izo antigens, this cell will present them to immune cells. That's why this macrophage is called antigen presenting cell, because it will present antigens it got from the processing of the injurious agent. Then these antigens will be presented to T helper cell. Then this T helper cell, it will induce two ways of immune system. So the humoral immune system, meaning they will now activate B lymphocytes to become plasma cells, because as you know, it's the plasma cell which produces antibodies. So this is one way. In another way, the T helper cell will send cytokines. Ibi ntabwo ari ukuvuga ngo hari ubundi bigiye gukora, ihitire kuri cytokines nka za tumor necrosis factor, interleukin 2, 12 n'ibindi, ikagenda iyo cytotoxic T cell ibibonye iri activated, and becoming activated now ziba itibyara izindi nyinshi nkazo zigahita zikwira umubiri wose, zigajya kurwanya aho zizabona ikintu cyose gisa n'iyi antigen T helper yabonye. T helper yo izatanga nabonye umwanzi umeze gutya, cytotoxic lymphocyte yitegure kurwanya umwanzi wese ukoze gutya. So that's why here you see now that this cytotoxic lymphocyte it is destroying infected cells. So murabizi ko cytotoxic T cells zica either cancer cells or virally infected cells, yaba epithelial cell or any other. So n'icyo immunite yacu ibikoraho. Hanyuma ku rundi ruhande umuntu akaba ari gukorana antibodies ku buryo niyongera kuba infected noneho hazaba yiteguye, ntabwo bizongera gutwara iyi process yose, ahubwo antibodies zizaba ziteguye. Ndetse hari n'ibindi bitari kugaragazwa hano, memory T cells na memory B cells n'ibindi zaba zihari, uburyo coronavirus iyo yongeye kugaruka umubiri uzayirwanya. So nyango niyo mpamvu bavuga ati abantu banduye baba iyo bongeye kwandura ntabwo bongera kuzanga, kandi evidence ngira ngo murazizi namwe ku giti cyanyu no muri literature. Abantu muzi banduye bwa mbere araremba, yanduye bwa kabiri ntiyaremba, cyangwa se yarakingiwe amaze gukingirwa nyuma ahubwo arandura ariko ntiyaremba. So izo cases muzi nicyo kisobanura ko umuntu yakingiwe aba yatewe antigen ijya gusa na coronavirus, cyangwa se coronavirus which is killed or attenuated. So ariko antigen zabo zigihari, iyi process yose igakorwa, hakaba memory cells, hakabaho na antibodies. So this explains the coronavirus. So now how it affects them, it damages our body, the body. So as we said, this virus will be received through these receptors. So it is the receptors ziganje cyane cyane muri gastrointestinal tract. Izindi zikaba muri respiratory system. Ariko nkuko bizana benshi bagiye bagiye ikintu cyangiritse cya mbere ni lungs, ariko hari n'abagiye bangirika impyiko, cyane cyane abafite diabete n'ibindi. So bivuga ko no izo receptors zirahari, cyane cyane kwa angiotensin converting enzyme murabizi gukora renin, ikorana na renin and so on. Renin iri muri kidney. So bigenda bitera, when this coronavirus enters, it will replicate bya bintu navuga gukora virion nyinshi. Then these virions which are made will be engulfed, presented or engulfed by macrophages, dendritic cells, and the endothelial cells. And then these ones, they will present antigen. The antigen will be presented by these cells. So the APC ni imwe muri these cells. But not only that, because there has been inflammation, there will be some cytokines which will be formed or released. So abantu rero benshi bapfa bicwa n'ikintu cytokines. No kuvuga our body reacts too much with a lot of cytokines, bigakora icyo bita cytokine storm. No kuvuga na amahindo ya cytokines. So murazibona zimwe ziri hano, izero n'iziyo ziza zikakora damage to different tissues. So no wako infection ya mbere aho izi bacteria zinjiye, izi virus zinjiye, si cyo kibazo gitera damage, ahubwo reaction tugera kuri izi bacteria, not to these viruses nicyo gitera damage. So I think other things, the cytokines, as we said, that the antigen presenting cells will process the virus and then present antigens to this T helper cell. T helper cell will differentiate to CD4 T cells, which will induce the release of cytokines and also cytotoxic T lymphocyte, the CD8. CD8 nizo zikunze kubamo cytotoxic T lymphocytes. Hanyuma CD4 zikajya gukorana na B cells to produce these antibodies. So this is humoral immunity because of antibodies, and this is cellular immunity. So and ibyo ngibyo ni pathophysiology. So ibyo tubona ku barwayi bituma bapfa, cyane cyane twibanda ku bihaha kuko abenshi bapfa bishwa n'icyo twita bronchopneumonia. So what happens, za cytokine storms icyo bitera ni iki? Harimo inducing fibrosis in the lungs, fibrosis in the kidneys, and so on. So ibyo niyo mpamvu bituma uzasanga rimwe na rimwe hari ijambo na kwita politike cyangwa iki bashaka kuvuga ngo yagize fibrotic lung disease, iyo badaja guterura ko ari ari coronavirus ya nyamurutanye. So nagiye mbona nk'abantu cyane cyane bo mu bihugu byateye imbere umuntu ukomeye wagiye yitwa na coronavirus n'icyo wagiye bavuga. So ikintu cya mbere kiba muri fibrosis, ikindi ni thrombosis. So ubu usanga harimo twa thrombose twinshi muri organs zabo cyane cyane mu bihaha. Thrombose, you understand, we saw this. So this is in a normal way. This how here we have alveolar sac with pneumocyte za type 1 and type 2. Ariko nk'uko tuzi harimo capillaries. Izi capillaries nizo zituma umwuka uje hano, oxygen irimo yinjira muri blood vessels, hanyuma gas carbonic dioxide irimo igasohoka. Ariko muri coronavirus murabona uko byagenze, twabyimbye kandi amaraso yibumbiramo biba clot. So this is thrombosis. So kimwe mu cyaje kigaragara muri aba barwayi ni kugira thrombosis in anywhere, so including here in the lungs. Ikindi hano, there will be a fluid and many other things within the alveoli, nkuko twabonye kuri bronchoni, kuri pneumonia. So ibyo byose bituma rero iyo abakoze x-ray babona rimwe na mubona igihoka kibura mwuka kubera ko there is no longer air. You see just opacity, so a solid things. So this is what happens. Nicho kibica abenshi ibingibi thrombosis kandi ntabwo ari gusa n'ubuzima bwa. So when the coronavirus came, we at Sashwika and Sashwibe we had got a grant, research grant funds to do research kureba niba navuze mbere ku bijyanye n'uko za clinical autopsy zidakora, ariko hariho proposal kuvuga ngo abantu batinya autopsies kubera ko kubona umuntu we umushwamiye n'ibindi bitamu. Okay, psychologically it hurts. So bati uwakoresha uburyo buta disfiguring umuntu ni ugufasha inshinge nini bigafata samples hirya no hino udafunguye umubiri hanyuma ukareba ko na diagnosis. So it had started in 2019. So koronije kubera ko twarebaga anything wese utishwe tari forensic, utishwe n'abantu cyangwa utiyahuye ahubwo bishwe n'uburwayi. So ariko impamvu itazi, so twarabikoraga. So koronije rero nabyo bihita byinjiramo to testinga coronavirus. So mubo twayibonyemo, unfortunately abo twayibonye bose nta n'umwe abaganga bandi bari baketse ko afite coronavirus. So asanga bakeka ibindi kamenyekana nyuma ko ariyo namutanye. Byumvikana ko batanabitekerejeho, ntibiyeze babyirinda, nabo bagiye banduza amanisha. Ariko bose twayisanga bizi thrombosis ari mu bihaha, ari mu mwijima, cyane cyane izo organe twayaga n'ubwonko hose wasangaga thrombosis is everywhere. So this is the most common cause of death in them. So apart from pneumonia itself, ariko thrombosis igenda ikaba no mu mpyiko, nira fibrosis ituma glomerular filtration itagishobotse, ibyo byose niyo bica abarwayi. And as you know, as I said here, you see that on this diagram, on this X-ray on the left, you see that you cannot see the lung on the right side. So there was a severe acute respiratory syndrome coronavirus. Okay, you name it. So on the left side, you can see at least a lung, but not really well. On this other X-ray is the same. Here you see opacity. So hanga hagomba ko ari umukara, hagomba ko harimo air, ntayirimo. Air iri kugaragara hano hake, hanga ntayo n'ahandi. So isa n'ari bronchopneumonia iriya ya Robira urebye architecture yaho ahanga. So nkuko nabwo habanje kubaho SARS-CoV ya mbere itarashyizweho umubare rimwe kuko nta ya kabiri yari ihari, ariko ubu basigaye bandika zo kabiri. So yagaragaye mu mwaka w'imbere ngo mu mwaka wa 2002, hanyuma mu 2012 haza indi yitwa MERS, nuko Middle East Respiratory Syndrome coronavirus. So yagaragaye muri Arabia Saudite. Ariko dusuye mu mateka, hari coronavirus ubwazo zabonetse mu myaka y'1967 gutyo, zirimo amoko ane. Hari iyi yitwa NL63, NL stands for Netherlands, so yabonetse mu Buholandi bwa mbere. Hari yitwa 229A, so akenshi bareba wenda mutations zabe ikibazo cyabereye mu yihe. So genome yayo uko iteye niyo barebaho rimwe na rimwe bakabaha iyi mibare niyo ikomoka ifite 63. So indi yitwa OC43 hakaba n'iyitwa HK stand for Hong Kong, niho yabonetse bwa mbere. So izi coronavirus enye zari zisanzweho, hari n'indi iriwe nandika yo yabonetse mu 68 yahise ibura, it disappeared, so ntiyongeye kuboneka. So izi enye zari zisanzwe. So there were samples taken here from Rwanda, from different health facilities. So it was just for other purposes. Ariko when then we did in 2018, we analyzed these viruses. Ariko hari ibindi twashaka genotype ngira nabivuze ubushize, uburyo umuntu ashobora guclearinga viruses bitewe na genomic makeup. And I was also genotyping, SNPs and so on. So aho ngaho rero twabonyemo n'ubundi abantu basanga ngo coronavirus izi types uko ari enye zari zirimo mu barwayi 480 twakoreho izo assays ngira ngo harimo 18 bari bafite izi coronavirus. So zari zihasanzwe kandi ni samples zafashwe mu bana batarengeje imyaka 5. So ngira ngo ibyo bishobora no kubafasha kumva no gusobanurira abantu coronavirus ntabwo ari ubwa mbere ibonetse, murabona ko yari hasanzwe mu Rwanda bwaho izi enye zari zisanzwe zihari, ariko ziba samples zafashwe muri 2012 and 2014 until 2014 bisobanura n'impamvu ko icyo gihe ntabwo assays zakoze zashakishije iyi MERS-CoV, ntabwo zayishakishije. Iyi SARS-CoV yo muri 2002 yo ntayabonetse. So nicyo nayivuga. So nk'uko mizero iyi ni virus yabonetse bwa mbere mu Bushinwa, kandi kugeza ejo bundi ku itariki ya 12 when I was preparing this. So ku isi yose hamaze kuboneka abantu 654 bayirwaye, imaze guhitana 6.6 so naho mu Rwanda imibare igaragaza 132 abapfuye 467. So this is in the summary. So we explained how it came, how it enters the body and what it does to cause damage, and the findings either at morphological level or at the X-ray. So I think this is what I can say on this disease. So here there is another picture, other pictures. So this is a true gross lung biopsy. Bigaragara ahantu banyujije umurongo w'umuhondo hagati ntabwo hasa n'ahandi. So here it is more solid, niyo kuri X-ray bigaragara ko idafitemo air naho ngaho. So otherwise ibindi nukubona ko muri alveoli huzemo fluids, hakazamo thrombosis. You see this vessel is thrombosed. So na bya bindi za complications za ischemia binasobanura impamvu abantu baribwa mu gatuza cyane abafashwe mu bihaha bibwa mu gatuza. Nuko thrombosis and ischemia it causes somewhere this blood was flowing. So this is immunohistochemistry in E. It was just to identify if there are inflammatory cells. So basanze ari T lymphocytes hano zari zirimo, they are positive to a marker called CD3 and so on. So another infection is tuberculosis. It is when it affects the lungs, it is caused by aerosolized Mycobacterium tuberculosis. So ibamo ibyo bita primary and maybe secondary tuberculosis. So iya mbere rero ikunda gufata ari akantu kamwe ugasanga afitemo kanodire kamwe, ugomba kuba umenyereye X-rays kugira ngo yemtete nkangaya bayigaragaza hano, kubera ko there is the opacity but in the center hari ahantu hari vide. So cyangwa se hasa n'umukara bisobanura ko ahantu hari vide. Iyo bayita Gone disease, Gone complex. No kuvuga Gone complex igizwe n'iki? There is a calcification, the explaining why there is opacity and the fibrosis around it. Byose kuri X-ray ntabwo gutandukanya calcification and fibrosis. Because of them, they show opacity. But in the center, there is a necrosis. Rimwe hakaba vide, niyo mpamvu hagaragara ko hari ahanarumba. Ikindi abafite nuko hira lymph nodes ahangaha that we don't see here, they will be also enlarged. So ibyo byombi iyo biteranyije, hira lymph nodes being enlarged and being necrotic and having this node during the lungs film later gone complex. So akenshi rero uyu muntu nta bimenyetso byinshi aba afite nko gukora papa byafashe akanya gato ashobora kubigira, but usually they are asymptomatic as written here. Ariko rimwe na ashobora kunanuka, akorora, umuntu iki akisuzumisha, hagira ukeka ati reka turebe na tuberculose, bagakora x-ray, bagakora and this profile protein derivative skin test, hanyuma yaba positive then bakamenya ko ari bakamusuzuma. So when you do a biopsy, you find a granulomatous inflammation. You saw that in inflammation in general pathology. Caseation ni byo bita fromage. Donc cyangwa se ufashe ingwa niba muzibuka ariko kugira ngo benshi mwize mu cyaro aho zikoreshwa, ingwa ukayitoba mu mazi makeya, ibyo ubona ibintu bivungagurika bijya gusa n'umuhondo weruruka, so niyo caseation cyangwa fromage. So niko ahantu hari tuberculosis habazo. So here it is a test bakora muri laboratory, babona acid fast bacilli, AFB means acid fast bacilli. Then when they are positive, these reddish ones, so nimurebe ibiri binini hari ututwa rods, because this bacteria have a rod shape. So these are positive. So this is in general. Then the secondary tuberculosis ibaho nk'uyu muntu wagize ya mbere, akenshi ntabwo biba bigaragara, ariko iba yari activated irakwira, ugasanga kwiriye wenda mu gihaha cyose cyangwa ibihaha byombi, yakagiramo ya manodire nk'ari ya gone cellular colonization. So ibyo kuboneka iyo umuntu afite immunity iri hasi cyane. So in patients, those infected by HIV, so mbere twebwe wenda tuki HIV yari kuyivura bikiri challenge, tuwiga medicine cyangwa tuyirangiza. Iyo umuntu yabaga agize tuberculose nibwo yavuga ko ari muri stage of ya sida cyangwa se AIDS. Otherwise umuntu wese ufite HIV ntabwo aba afite sida. Sida ni uburwayi igihe umuntu yarembye ubwo ko yagize sida, naho ndabwira abafite agakoko gatera sida ntabwo arwaye sida. So this was one of defining the conditions to say this person now is in the stage of AIDS. So uretse iyo ngiyo ikwirakwira ukabona ni ya manodire, hari noneho indi kwirakwira idakora nodire ahubwo arankayima yose igafatwa. So imeze nkaho ari interstitial pneumonia, but caused by tuberculosis. So you're miliary tuberculosis. So tuberculosis we present it here for lungs, but it affects many organs, most of the organs. Any organ can be affected. Ndavuga ibyo nabonye ku cyanjye, ari mu gifu, abayifite mu gifu, abayifite muri overe, abayifite muri abayifite muri fallopian tubes, abayifite muri kidney I mentioned, mu bwonko, mu magufwa, ahantu hose, muri testis, ahantu hose turazibona. So it can affect any organ, but essentially also lymph nodes. Lymph nodes ngira ngo asashwe ntabwo ku mwaka turaba abantu barenga 100 bayigize yagaragaye muri lymph node kandi bihaha batafitanye. So we call it extra pulmonary tuberculosis. So murabizi ko yafashe lumbar vertebrae bayita Pott's disease, mu Gifaransa ni mal de Pott. So any questions so far for the infections? So chronic obstructive pulmonary disease, izi ni indwara zifata abantu zituma guhumeka either kwinjiza umwuka cyangwa kuwusohora cyane, bikaterwa n'impamvu zitandukanye nk'uko tubibona. So this is a group of diseases characterized by airway obstruction. Lung does not empty and air is trapped. So the consequences is that there will be the volume of the air that can be forcefully expelled is decreased. This is what they call forced volume. Okay, I will check what it is written somewhere, but I saw it in physiology. So the capacity, I think. So this is C. So especially during the first second of expiration. So no kuvuga expiration volume nayo iragabanuka, hanyuma ratio of expiration volume as compared to the forced volume nayo ikagabanuka. So these terms we saw them in physiology. So hari uburyo ubwira umuntu ngo nahumeke n'imbaraga nyinshi, donc ashyizemo imbaraga asohora umwuka cyangwa awinjize angana n'icyo bashaka kuvuga. Noneho bagapima volume asohoye ingana gute cyangwa se volume yinjije ingana gute. So the total lung capacity TLC, so C is capacity, is usually increased due to air trapping. So as a result, ikibazo abantu bagira kenshi nubwo bamwe ikibazo kwinjiza umwuka, ariko ikibazo gikomeye kuri no kusohora. Yango no kundwara nka asthma niko bigenda. Umwuka arawinjiza ariko kusohora agakoresha imbaraga kandi agafata umwanya muri nasohora umwuka. So there are many causes then, so we will not maybe take time here on these diagrams. But here you can see the normal bronchial and the normal alveolus, but in the diseased ones, the COPD, you can see that here, for example, in this bronchial, the thickness of the air is increased. So when the thickness increases, it means the lumen decreases, the caliber decreases. And also there is a mucus flowing here, which is not here. So mucus sana iriyongera ikaba nyinshi nayo ubwayo ikajena umwuka na space yari isigaye yuzuramo mucus. So for the alveoli, ahangaha ni urugero twagize icyo bita emphysema, ziraturika umwuka ukava muri alveoli ukisohokera hanze. So we shall see details, or we have seen them. So the first one is chronic bronchitis. Abani nk'abantu bahora bakorora a dry cough. And sometimes when it is a long time, it becomes productive, especially when there is an infection which is added there. So here there is a history. If you have someone having a cough for more than 3 months for 2 years, so productive cough for more than 3 months for 2 years. So icyo bivuga nuko ntabwo ubundi igihe cyose abakorora, ahubwo agira za episodes. Ukuvuga nko mu gihe cy'itumba agakorora amezi 3 yose agashira. Igihe cy'izuba cyaza agasa n'uworohewe. Undi mwaka waza nanone agafata andi mezi nibura 3 ameze gutya. So nubana ibintu bisubiraho. Icyo gihe bigaragaza ko afite chronic disease. It is recurrent. So in the normal way, you see that the caliber here is in large, but here the caliber is decreased because the thickness of the air is increased. So ikindi bavugamo nuko goblet cells, they are increased in number, kandi nazo zikora mucus. Ira mucus ikaba nyinshi kubera ko goblet cells ziyongereye. And here there is also a diagram I added just for you to know the difference between chronic bronchitis and acute bronchitis. So, okay, you have read them, you read them, but it is not just difficult to read. So at the end, these people, they will have productive cough due to excessive mucus production, cyanosis. Cyanosis ni murabizi y'umuntu afite umwuka iyo amaraso ye atarimo oxygen ihagije, harimo gas carbonic. There is a tendency yuko amaraso ajya gusa n'umukara cyangwa ubururu. So this is because abantu batinjiza umwuka uko bikwiriye, cyangwa cyane cyane asohore wa mwuka urimo gazi carbonique usohoke. Ibyo bituma amaraso akomeza kuba rich in carbon dioxide. That's why they have this cyanosis. So, and of course, because of this mucus which will be stagnant there, which is called mucus plugs, they have an increased risk of infection and the cor pulmonale. So cor pulmonale, it is just a set of conditions which come when someone has right heart failure. So right heart failure hano izaza gute? Ni ukubera ko ibi mu gihe ibihaha byangiritse, umutima uzayikoresha imbaraga nyinshi ngo wohereze amaraso mu bihaha kubera ko byifunga vessels somewhere and so on. So mu gukoresha izo mbaraga rero umutima nawo uzongera failing. So that is called pulmonary. So apart from bronchitis, the second disease in this category nyirango nenye ubundi zikunda kuvugwa muri COP, the second one is emphysema. So emphysema muri rusange ni ibintu byoroshye, ni ukuvuga there is a destruction of alveolar air sacs. Sacs, umwuka uva mu bihaha ukinjira muri interstitial tissue. So muzajya mubibona nk'umuntu yakoze accident agira ikintu kitobora ibihaha ho gato, noneho umwuka uhita usohoka waparuka mu kwaha kwe ukumvamo twa tuntu bavuga batwaramo ibikoresho biva mu mahanga kudushashi, wakora ukumva ni utuntu tw'utubure twuzuyemo umwuka wumva turagurika nk'amasha. So that is a sign that hari emphysema, bivuga ko hari igihaha cyashwanyutse umwuka winjira mu nda. So muri rusange nicyo twita emphysema. Ariko se hari n'ishobora guterwa n'icyo twakwita icyitari traumatism itewe n'ikibazo cy'amaprotease n'ibindi protease and antiproteases imbalance. So they say that inflammation in the lung normally it will cause the release of protease by neutrophils and macrophages. And alpha-1 antitrypsin A1AT will neutralize the proteases. Proteases, understand, these are enzymes which will destroy proteins. Excessive inflammation or lack of the antitrypsin, alpha-1 antitrypsin, will lead to destruction of the alveolar air sacs. Kubera iki? Kubera ko antitrypsin yagombaga guhagarika proteases izaba itahari, cyangwa se habayeho gukora proteases nyinshi by neutrophils in this inflammation, bizatuma air sacs zishwanyuka proteases will destroy protein. Therefore, usange kamwe karacitse umwuka, the air will diffuse. So this is another explanation of emphysema, which is not traumatic, which is just I can say endogenous. So it is known that people who smoke, they have a high risk to have emphysema. Why? Because the pollutant in the smoke will cause excessive inflammation, and therefore they will cause neutrophils come in, and neutrophils they will release proteases, and the proteases will damage the alveoli. So this will result in a central acinar emphysema that is most severe in the upper lobes usually. So you see, this is a diagram. This is in the lower lobes. You see here that the lungs is it is almost solid. Ariko hanga urabona hazemo udupockets twinshi. Normally alveoli ntabwo ari ikintu ushobora kubonesha amaso. Usiye kubona kuri yawe ndatari very solid organ, ariko ntabwo alveoli wabangwa ngakara kamwe ngakara kano. They are microscopic. Ariko ku muntu wagize emphysema ubona udupocket nk'utu. No kuvuga biterwa n'iki, alveoli nyinshi zirashwanyuka hagasigara nka wenda tuvuge nka alveoli 100 zigahinduka alveolus imwe, bityo ukaba wayibona n'amaso. So this is an example I was giving. So but this is a diagram. When you on the lower part here you have a true picture where we have the normal lung. You see it here. Can see that it is brownish, but you cannot appreciate the alveoli. But here you see things which are like those of the honeycomb. Abantu basize agashushanyo ka honeycomb kira kintu inzuki zishyiramo ubuki. So niko ibyo byabaye kubera many large pockets of air resulting from destruction of some alveoli. So when you want to confirm that it is emphysema and there is a deficiency in the alpha-1 antitrypsin, you can do immunohistochemistry. So you can do special stains. So it will be PAS positive. PAS is a periodic acid shift. I think you have seen it in some other courses such as microbiology. So tukura turimo hano, it is a positivity to this one. But this was the liver, not the diana. So the disease severity is based on the deficiency of this alpha-1 antitrypsin. So hari ibibazo by'amagene abantu basanga gene. So ahangaha barasobanura impamvu. So PIM is the normal array. 2 copies are usually expressed. So PIZ is the most common clinically relevant mutation. So meaning that when this gene is mutated by PIZ. So nicyo bigaragara. So iyo hariho PIZ mutations, then habaho neutrophil elastase burden iriyongera. Mu gihe hari PIM habaho balance nk'uko bibona iyi ni umunzane n'umukoreshwa mu by'amategeko. Ni ukuvuga ko alpha-1 antitrypsin protection is balanced with the neutrophil esterase burden. So birabalansanya ku buryo habamo icyo twita homeostasis. Ariko niba neutrophil esterase zibaye nyinshi cyane kurusha antitrypsin, then you see what happens. The person will develop emphysema, and this is usually seen when there is a mutation in this gene, which becomes PIZZ. So probably smoking also, mutations zitera cancer, but also it can cause a mutation in this gene and therefore cause this imbalance you see here. So the clinical features of emphysema are one of the dyspnea, so difficulty in breathing, cough with minimal sputum. So the dry cough. Muri chronic bronchitis twabonye ko bagira prurient productive cough, sometimes which is harimo pus. While ahangaha harimo it is mostly dry cough. So ikindi twabonye ko muri chronic bronchitis baba cyanotic. So uruhu rwabo ruba blue cyane cyane abafite uruhu rwera. Ariko hano muri emphysema it is the opposite. They are more pink. I think it is written here. Increased pink skin. So ikindi iminwa yabo uko ahumeka n'iminwa ibikina, that's why past the lip breathing. Ni nacyo cyatumye hano hazamo pink puffer. This puffer comes from this past lip and so on. So this diagram is just comparing chronic bronchitis and emphysema, and you understand that there is a great difference. So in bronchitis, the issue is with bronchi, while in emphysema, the issue is with alveoli. In bronchitis, you have a productive cough. In emphysema, we have a dry cough, and so on. So there are other differences. And the on X-ray, emphysema azagira barrel chest. So biterwa n'ikirere nguyu uko yinjiza umwuka urinjira kuko nta kiwutega, si nko muri chronic bronchitis aho kwinjira bigora. Aho urinjira ahubwo ugasanga ababaye zaratobotse umwuka kenshi ukuzura ahantu ku buryo iyo ukoze expiration umwuka usohora. So iyo wongeye kwinjiza umwuka biremera, ariko wasohora inyinshi ntusohoke kwigumira hari. So ibyo bituma uko ugenda uhumeka umwuka usigara muri thorax uba mwinshi, noneho ikabyimba, thorax ikabyimba, aribyo bibara barrel chest. So usually the treatment of emphysema, iyo nk'iriya yatewe na traumatism nka gisida n'ibindi, ushyiramo tube, ufata tube ukayinyuza nko muri port, muhamuzi anatomically ahanyura za vessels, unyuze muri ribs, hafi ya ribs aho ziruka hirinda. So ukinjiza tube muri thorax ariko ukirinda nane gutobora ibintu ntubigere. So muri pleural cavity ukayinjizamo umwuka wose wari by entrapted there uzasohoka muri ya tube, noneho umuntu abone ko barrel chest itangiye kuvaho agatuza kongere kabe kazima. So it is what is done, but make sure when you do it you don't cause more emphysema by destroying further or additional alveoli. So the third disease is asthma. So asthma ureze ni indwara allergique, ariko abantu bafite nabo icyo bagira ni ikintu bagira the thickness of the walls of the bronchi will increase. Ibyo bituma umwuka kwinjira no gusohoka bigorana, ariko ikibazo gikomeye kuri asthma kiba n'ubundi gusohoka k'umwuka kurusha kwinjira. So they have bronchoconstriction most often due to allergic stimuli. So this is the atopic asthma. So usually it presents in childhood, ugasanga umwana ahorana za rhinitis, allergic rhinitis, ahorana chronic bronchiolitis, not bronchitis, bronchiolitis, meaning inflammation of the very small vessels, not the larger ones. So uzasanga abana kenshi ntabwo umwana wavuga ngo afite asthma ko bishobora no gutera trauma ku babyeyi cyangwa bo bene wabo, ahubwo icyo gihe akenshi bandika ko afite chronic bronchiolitis. So iyo arengeje imyaka 7 akibigera nibwo bemeza ati noneho we can confirm this is asthma. So productive cough. This they have a productive cough in difference to the okay, it is the same as in the chronic bronchitis icyo bagihuriyeho with spiral shaped mucus plugs bita Cashman spiral, nkuko ubona hano bimeze nka spiral metal. So niyo mpamvu yitwa gutyo, but this is seen in histology or in cytology. So other things they do, eosinophilic derived crystals called charcoal-laden crystals, which are shown here. Asthma may also arise from non-allergic causes such as exercise, viral infection, aspirin intolerant asthma, nyabarano twabigezeho mbere, hari abayigira aspirin intolerant asthma, and occupational exposure, umuntu ukora ahantu hari dust, ukora mu ruganda rwa sima and so on, ashobora kugira ikintu cyemeze asthma which is not atopic. So icyo bimusaba kwa. So when you examine this patient now after bronchiolitis, iyo asohora umwuka wumva akantu kavuga nk'agasifre cyangwa agahinyoni cyangwa ikoni ry'imodoka cyangwa mu twumva tuvugamo, iyo abigize ko asohora umwuka, then you can confirm bronchiolitis or tendency to have asthma. So here there is a pathogenesis explaining how things are done. So allergen, like pollen, it will be captured on the mucus. It will attach on the mucus lining, the respiratory epithelium. Then there will be activation of T2 cell, because these cells they will present antigens from the pollen to the B cells and the T helper cells and so on. So until we have IgE production by plasma cells, IgE, you know, this is the antibody which is related to allergic reactions. And so on, mast cells will also release mediators such as histamine and so on. So this is what is explained here. No, is these mediators such as histamine n'izindi nizo zizatuma habaho ya vaso ya bronchoconstriction ituma umwuka utinjira. So nicyo kizabitera, ntabwo ari uko allergen zabagezeho ubwazo, ahubwo ni izo histamine n'ibindi. Niyo mpamvu uzasanga kenshi umuntu afite allergy uzasanga umugabo bati reka tumuhe antihistaminic, meaning the drug to neutralize histamine. All the histamine is the one inducing a bronchoconstriction. Muri inflammation mwabonye ko itera vasodilation. So kuri blood vessels itera dilation, kuri bronchi igatera constriction. These are the opposite things which are opposed. So the fourth disease is the bronchiectasis. This is a permanent dilation of bronchi loss of airway tone, which results in air trapping. So muri izi ndwara uko ari enye twavuga ko eshatu zose they concern bronchi or bronchial, while another one is concerning alveoli, and that is emphysema. So the air is entrapped, so it doesn't go out, but you can you can breathe in another air and so on. So the signs, it is cough, dyspnea, and full smelling sputum. So because of added infection. So complications include hypoglycemia, hypoxemia, and choropulmonary, and the secondary amyloidosis caused by that chronic inflammation. So you see here we have this bronchus, you know, it's wall, it has a muscle inside. So here we have, it is dilated, as you see, compared to this one. The lumen is dilated, but there is a mucus inside there, which will cause the air to be entrapped inside there. So we now have the bronchoconstriction, ahubwo afite icyo twita bronchodilation, but which will be bad because there will be stagnation of mucus, and therefore mucus. So that is bronchiectasis. So when you will suspect bronchiectasis, so here we have pictures. So here we have a CT scan pictures to show you. Of course, this I cannot say as a general practitioner you can diagnose this. You can suspect, but you cannot maybe interpret this unless you have further training. But there are some diseases which can cause a bronchiectasis. Not tuberculosis zishobora gutera that, because of bronchiectasis, it is just a presentation of how the bronchial tree is. It is not about bacteria and so on. So it can be caused by traumatism, can be caused by foreign body, it can be caused by infectious, post-infectious conditions. This is that scarring and so on. So it is due to severe inflammation with damage in airway walls. The causes include cystic fibrosis. This you may have seen it in biochemistry, maybe ariko nanjye nayivuzeho mvuga ikibazo cy'abantu bagira muri za pompe za sodium na chloride. So ugasanga afite chloride nyinshi muri we, cyangwa afite uko bayipima mu byuya ibirimo chloride nyinshi. So I will not go back to that pathophysiology because I suppose you have seen it. But icyo biza gukura nkuko nigeze kubivugaho nuko abantu bagira most of their organs such as a pancreas, salivary glands, and the lungs, they become fibrotic. So, but in that fibrosis, you can see some pockets which are filled with fluid. So now we have cystic fibrosis. So you see fibrous tissue, fibrosis, and you see some pockets of fluid inside there. So you have cystic fibrosis. And here, this diagram explains what happens to have that. A normal airway here. Then with chronic inflammation, you see that there will be many goblet cells here. They will be increased, and you know they are the ones producing mucin, mucus. So here you see that mucus is too much increased. The mucus nayo ubwayo niyo twabonye ko ishobora gutera entrapment of the air. So we have many macrophages. Ni bisanzwe ko tugira alveolar macrophages, but here they have increased. We have elastase with this enzyme which cause epithelial cell injury. Then with all these things, ikibazo hano berekana ngo vicious vortex cyangwa vicious cycle. Nukuvuga yakazo kamwe kaje gahereza kandi bikazongera bikagaruka, ibibazo bikarushaho kugenda byiyongera. So nibeta mu Faransa cercle vicieux. Haje akantu kagiye gakurura ibikomeye kurushaho. So then at the end, you have too much inflammation mediated by T helper 19 cell T lymphocytes, and you have a lot of chemokines and the cytokines, the proteases, and so on. So this is what happens. So I'm going to Catena syndrome. I think it is explained here. It is seen when people they have sinusitis, infertility because of poor motility of sperm, and the situs and versus position of major organs reversed means ibigomba kujya iburyo byagize motion. So other cause they are allergic bronchopulmonary aspergillosis. Aspergillus, you know, this is a fungus. So it can cause allergic reactions. So that's all. We have 4 types of diseases of chronic obstructive pulmonary diseases. So there's the 4 ones you should know them, the main difference between them, and what you can do to diagnose one or the other. Any questions so far? So it seems not, then we'll continue. Yes, you can talk. Okay, so let's continue. So the basic principles for constrictive diseases is in indwara zishobora gutuma ibihaha bitaba free gukora, no kuvuga n'ibinjiza umwuka bigare nini n'usohora bigabanuke bunini bwayo. So ni kimwe na ziriya ndwara tubonye zindi hejuru za obstructive pulmonary diseases. This is also a group of diseases which can cause these things. Harimo n'ibiri mechanical twakwita indwara ibintu cyose cyatuma ibihaha bitinyagamura. So there will be restricted feeling in the lungs with total lung capacity which is decreased. Jango hano kuri diagram wagenda bibona forced expiratory volume in 1 second. So it is presented here. So the forced vital capacity is very much decreased, and the ratio of forced expiratory volume to forced vital capacity is very much decreased. So I think this you have seen it also in the previous diseases. So most commonly is it due to interstitial diseases of the lungs, but may also rise with chest wall abnormalities such as massive obesity. Umuntu obese cyane akagira ibinure mu byinshi hano imbere, hanyuma bigasunikira igihaha kikaba. So you see on this diagram how this left lung it became very small because there is something here. Maybe it is a fluid or fat in obese people, which is there. Ikindi ni pneumothorax, no kuvuga umuntu yagize ikibazo hano hinjira umwuka muri pleural cavities. Ni nacyo kiba muri emphysema. Emphysema umwuka ntabwo urangira gusa ujya no munsi y'uruhu, wakora palpation ukumva ko twatuntu turagurikana vuba, ariko ibyo biba kenshi naha hari undi mwuka wuzuye mahangari nawo navuze ko ushobora kuwusohoramo ukoresheje tube that you insert in between the ribs. So iyo ugiye insertingamo tube nabivuze ugomba kwitondera vessels. So nyabo muri anatomy murabizi vessels zinyura ntabwo ziba zinyura hejuru ya rib, ahubwo zinyura munsi yayo. So nuba igiye gukora procedure ko yinjira muri thorax, wirinda kunyura directly below the rib ahayegere, ahubwo ujya hejuru ya rib ikurikiye. So this is what must be done. So the causes may be parenchymal nka interstitial pulmonary fibrosis, cyo cyatuma fibrosis for the lung iba bisatumugamuka. It can be primary or idiopathic, occupational, chorogenic, granulomatous, irradiation, resection, drug induced, and so on. So it can be caused by extra parenchymal causes such as abdomen. Umuntu ufite inda nini n'ubundi bandi ba obesity biragaruka, inda zabo zari nini ku buryo zisunika diaphragm, then ibihaha nibone uko by'inyagamo. and ni nka bimwe twabonye ku mutima bita cardiac tamponade. So the restrictive lung disease also, we have the causes from the pleural effusion. Nibyo navuga pneumothorax, harimo fluid, pleural fibrosis, pleural tumors such as mesothelioma, pleural thickening for an lesion. And then we have chest wall. Hashobora kuba trauma kuri ribs. Icyo gihe bituma niyo winjiza umwuka mwinshi uratonekara n'ibindi. Ankylosing spondylitis and many other causes which can be hindering the lungs to work properly. So there is that idiopathic pulmonary fibrosis, which is among the causes of this constrictive conditions. So in a healthy way, so we have here alveoli and so on. And when there is a problem, what we see here is that we have alveoli, they have changed their architecture. There is a fibrocyte or fibroblasts which have deposited too much fibers around there, so causing the fibrosis. And therefore, this also will have a consequence on the exchange between oxygen and the dioxide, carbon dioxide. Because of what? Because the wall of the alveolus has increased in its diameter, can you say so? So here it has increased. Therefore, the exchange between the gases will not take place optimally as it is in a normal person. Sorry, I'm going to back. So another disease is the pneumoconiosis. This also, it is interstitial fibrosis due to occupational exposure. So biterwa n'ibintu byinshi, hari abakora mu nganda zirimo za carbon cyane, carbon dust nyinshi, abantu bakora muri sima cyangwa hari dust zirimo carbon nyinshi, gukora ibintu by'amakara cyane and so on. Silicosis because of silica, berylliosis, those working in industries with beryllium, and asbestosis, so it doesn't cause only cancers, it also induces diseases such as this one. So it means that if you become like an occupational physician, umuganga ushinzwe kuvura indwara ziterwa n'ibyo abantu bakora, you must know these ones. Hari ibigo biba bifite cyane cyane nka Rwanda Social Security Board, kubera ko hari abantu baza kuvuga ngo jewe nangirijwe n'akazi kubera iyo mpamvu ngomba guhabwa indemnity and so on. So umuntu ukora akenshi n'abaganga general practitioners, so agomba gusobanukirwa n'ibi ngibi, kumenya izi ndwara ziterwa n'akazi umuntu akora kuko ni izi. Hato umuntu atazaza akavuga ati jewe nkora kubera ko nkora mu igaraje ko zizamo modoka, ndumva afite asbestosis muri myaka kandi umva ntawe bihuriye. Wenda aba mu za asbestosis ibyo ntibimureba, ariko ntawe bihuriye n'akazi. So you have to be clever in that case to know which job is related to which disease. So another condition is sarcoidosis. So it is one of granulomatous diseases. Ibijya gusa na tuberculosis kuri histology with giant cells, ariko ikitagaragara mano nuko there is no causation. Imwe bimeze nka famaje kavuga ntabwo bigiye. So the real cause is not yet known of sarcoidosis. So there are many theories, but until now nobody knows the real cause of this. Ariko ni indwara igaragara benshi. So said that the theory is not known, but there is they think there is something, a cause and a theory, which will make this CD4 T helper cells to respond to that antigen, but the antigen is not yet identified. But on the histology, you see what we call asteroid bodies, and so on. So pulmonary hypertension. So ngira ngo ni ibintu byumvikana ni igihe habayeho kwiyongera kwa blood pressure within the pulmonary arteries. So if it is more than 25 millimeters mercury, it is a big problem because the normal is 10. So it is characterized by atherosclerosis of pulmonary trunks, muscle hypertrophy of the pulmonary arteries. Ni isanzwe iyo hari hypertension, kubera gukoresha imbaraga nyinshi aho ngaho bituma haba hypertrophy of the muscle. And this means also that the right heart, its ventricle will be also hypertrophied. Mu gihe muri systemic hypertension, yo ubusanzwe it is the left heart which will be hypertrophied. So there is primary and secondary. So primary primary pulmonary hypertension, it is usually seen in young adult females. The etiology not known. Because when you know the etiology, then it becomes a secondary pulmonary hypertension. And usually this patient will have also chronic obstructive pulmonary disease and so on. So there is a classification by WHO, ni ukuvuga umurwayi afite idiopathic pulmonary hypertension, hereditary and so on. Both was under group 1. Group 2, it will be due to left heart disease. So umutima w'ibumoso wagize ikibazo, ni ukuvuga ko ntabwo wakira amaraso akomotse avuye gusukurwa mu bihaha, bityo niyuzura agasa naho asubirayo, asubira mu bihaha bizangirika, mu kwangirika bizagira na consequence ku bihaha ubwabyo, then the right process. So you understand that it is a long process. And so we have 5 groups by the World Health Organization. So going to respiratory distress syndromes, it can be acute, usually. Acute, but the acute, they are the ones which are really problematic. Ngira ngo murabyumva ko na COVID uburyo igaragara ishobora kuzamo ahangaha by presence muri infections, ariko the way clinical, the way it presents itself, it is the acute, it's the acute respiratory distress syndrome. Ni nayo mpamvu ya virus yitwa severe acute respiratory syndrome, coronavirus 2. So murabyumva ko ifite. So ariko izi ndwara zidatewe na COVID zari zisanzweho, turazibona mu bana bakivuka, cyane abana bavutse batujije igihe, preterm cyangwa se premature children, badashobora gukora surfactant ngo yagure alveoli, ahubwo zikaba flattened, akenshi hazamo izi membranes. So you see reddish membrane, pink membranes here. And you understand that if there are these membranes in the alveoli, the gas exchange will not take place as it should be. So X-ray will be difficult, of course, to interpret, but it is what's called white out on chest X-ray because there are areas which are opaque. So the causes, there can be or pathophysiology can have indirect lung injury and direct lung injuries such as pneumonia and so on. Or this they can have consequences. And so there is loss of alveolar capillary biliary integrity. And here we have more chemicals. So pumps, this is pathogen associated molecular patterns. Ni ukuvuga iyo umuntu abaye they are infected by pathogen, this pathogen will induce many molecules to be released. So in the set of all these antigen, these molecules need to be pathogen associated associated molecular patterns, while the dumps it is damage associated molecular patterns. So there are molecules which are released by any tissue which is damaged. So I recover molecular measure, cytokines and so on. So that's why I have them here. Then they will cause this neutrophil extravasation. We have many problems with fluid and so on, as we saw in the acute inflammation. So there will be loss of type 2 pneumocytes, arizo zikora surfactant, ni urugero noneho kubera idahari habeho collapse of alveoli, but also the scarring and fibrosis. So the respiratory distress syndrome can, I think this is what I was saying, deficient surfactant in the lining of the alveoli in the premature infants. So niyo mpamvu uzasanga uzabona niba muri protect na muri gynecology, uzabona iyo umudamu afite bigaragara ko ashobora kubyara igihe kitageze, kubera ko mubibona ibyo bita menace, aba ari menace d'accouchement prématuré, threatens to have a premature delivery. So icyo gihe mubona byanze kunze bisaba umudamu imiti ituma umwana wakora surfactant, kubera ko umwana utarageza igihe cyo kuvuka ubundi ntabwo afite surfactant ku mezi 7 bitarakora. So umwana ari umwana ashobora kuvuga ku mezi 7 mukanyena imiti ituma umwana we atangira gukora surfactant, kugira ngo navuka atazahura n'iki kibazo. So niyo mpamvu ya. So first, why do you think we are giving these drugs to this mom who has a risk to have a premature delivery? That is the reason. Is it to help the child, the fetus, to synthesize surfactant so that if premature delivery happens, then it will be possible for him or her not to be affected by the distress syndrome. So neonatal respiratory distress syndrome, I think, is associated with prematurity, especially surfactant production begins at 28 months. Adequate levels are not reached until 34 weeks. So ibyumweru 28 ishobora kubangurwa n'amezi 7 ariko ubundi abataruzura uko kwa muganga biba hari ibyumweru 2 bisa n'ibipfiramo umwana batarakorwa. So kuko ibyumweru tubiha dukurikije the last time umudamu yagiye muri menses. So hagati y'igihe ya menses za nyuma n'igihe yasamiye hanyuramo ibyumweru ni nka 2. Niyo mpamvu hari ibintu bipfiramo rero iyo tubara, iyo bavuze ibyumweru 28 bahera igihe yagiriye the last menses, ariko ntabwo ari igihe yasamiye. Usama biza nyuma y'ibyumweru nibura 2 uvuye kuri menses. So that's why 28 weeks, it is like 6 months and a half. So here they're explaining how these surfactants were produced and what it does and the consequences of not having enough surfactant, as we saw. Ikindi hano berekana uko umudamu ufite diabete kwa kwa bahabwa imiti ya insuline, imiti ya insuline ituma umwana adakora surfactant ihagije. Yumvikana ko ashobora no kubyara umwana ushyitse igihe yegeze ariko umwana adafite surfactant. So ibisobanura ko niba ufite umudamu ukurikirana atwite arwaye diabete atwite igihe azabyara, you must predict that the child may develop distress syndrome and therefore do preventive measures. So the signs that there are many hypoxemia with cyanosis, the alveoli membrane are filled with that pinkish material. These are the protein deposited there. Raised respiratory rate, use accessory muscles. Usanga humeka muscles zose azikoresha ubona ari nk'umuntu uri niba sport niba iki ahangayitse. Intercostal recession, so mu gifaransa byita tirage intercostal, ni ukuvuga ubona muscles ziri hagati ya lips nazo ubwazo ziri contracta cyangwa se yakwinjiza umwango yawusohora ukabona zirazamuka ngo ziramanuka. And subcostal recession, intercostal and subcostal, maybe this is a substernum. So na ubona sternum nayo igenda ibyina, so ni ibintu biteye ubwoba niko umuntu umwana ageze ngaho aba ari gusufura cyane. Nazo flaring, uko ahumeka n'amazuru agenda abyina. So ubundi ubusanzwe n'ahumeka ntabwo ubona izuru rikora muvoma, ariko when a child is suffering like that niko bigenda. So other signs are cyanosis, abnormal airway noises, on expectation, and so on. So we are heading to the end. So the lung cancer, I think you have seen that the lung cancer, so it is the most common cancer worldwide. And the most commonly diagnosed, okay, is the most cause of cancer mu type 1. So nayo yica abantu benshi ku isi muri rusange, abagabo n'abagore. Iyo urebye mu bagabo niyo iba diagnosed ari nyinshi, mu bagore ho nibere niba nyinshi, ariko kubera ko cancer y'ibere ivurwa navuga ku buryo biyegeye imbere kurushaho, abicwa na cancer y'ibere ntabwo ari benshi nk'uko ibihaha bimeze. So the most risk factor is cigarette smoking, and we have seen carcinogenesis that in a cigarette we have a lot of carcinogens. So they have a polycyclic aromatic hydrocarbons and so on. So another risk factor is radon, which is formed by radioactive decay of uranium. So dushobora kuvuga ngo nta uranium dufite hano, ariko mu butaka hari ubwo ibihara kudashobora kubicukura dukeya, byo bikunda kugaragara mu mazu, cyane cyane amazu afite za cave, muri cave cyangwa inzu itageretse, tuvuga itarimo sima and so on, cyangwa se ahandi hose yatuma haba contact na soil, biroroshye ko iyo radon iza nayo igatera ibibazo. So bivuga ko umuntu ashobora kugira lung cancer atanywa itabi, nta naho ahurira n'abandi barimo, ahubwo ugasanga ni iyi radon, kibaza se ko atakora muri aho bacukura uranium, uko nta nayo tujya mu ngamba byagenze mu. So that is the explanation. So environmental toxins include asbestos, nk'uko mwabibonye leta y'u Rwanda yakoze igikorwa cyo kuzivana ku mazu menshi, zimaze kuvaho cyane cyane ya leta, ibigo bya leta. So and you have many other things there, arsenic, chromium, nickel. So the common symptoms of them, they have a persistent cough, shortness of breath, a coughing of blood, unexplained weight loss. So n'ibindi akaribwa amaboko, chest, mu mugongo, repeated respiratory infections, akahora kwa muganga bakamuha antibiotics, ejo nakongera. So kirago ikintu ntavuze muri signe za chronic obstructive pulmonary disease, ikintu kibaranga nibyo bita digital clubbings. Usanga inzara ze zarihinnye, ubundi inzara zigomba kuba zirambuye, zarigondoye. Urabibona ngira ngo hari abarwayi muzayamubona babifite gutyo. Ikindi kimuranga iyo agiye ahantu azamutse muri altitude, yenda tuvuge ubwabyo kuzamuka umusozi biragoye kuko nta mbaraga bafite nyinshi, nubwo benshi bakora akazi, ariko iyo mufite ku kazi mubakoresha gake gashoboka, ntabwo umuntu mwinshi. So ariko tubafashe imodoka azamutse imisozi, ageze ku musozi ahantu hejuru, azahita akora businga kubera ko kuzamuka pressure ya air ikagabanuka, oxygen hejuru cyane ibiri kugabanuka, atangira gusufura agahita gusohoka. Icyo gihe bonye bimubayeho muramwihutana mukamumanura hasi aho hari oxygen nyinshi. So atanaye bajya kuba so digital clubbing, usanga intoki hejuru mu kumpera z'intoki harabyimba cyane n'inzara zikihinda. Iyo nazireba zirazabaye umukara, ya sinuses uranayibona no ku bantu birabura cyane urabibona. So it is not easy to see sometimes most of the regions in X-ray or in the lungs. Ariko nka tumor, when you are very careful, you can see here a nodule, you can see that there is opacity somewhere here. So when it is circumscribed, there are no signs of tuberculosis to say it is a gone complex, then it will be a tumor, and also we see if the patient is having an ophthisis, is coughing blood, or there is an unexplained weight loss. Ikindi twavuga nuko hari ibyo twita paraneoplastic syndrome, ni ukuvuga umurwayi ufite kanseri runaka agira ibimenyetso nk'ibyo ufite ikibazo ku yindi organe itarebwa n'iyo kanseri. So hari abantu bafite kanseri y'ibihaha bakunda kugira gukora za hormone, hormone zikorwa na adrenal gland, ugasanga afite ibimenyetso by'umuntu ufite ikibazo cya adrenal gland kandi nta kibazo cya paraneoplastic syndrome. ku buryo ushobora kubibona ukaba this is just a metabolic disease or too much hormone aldosterone and so on, ukamwohereza kuri endocrinologists, but you must think always about this. Mu gihe ukeka icyo kwanza, you must exclude the lung cancer or any other cancer which can do so. So most important to know for you, you are not yet a pathologist or lung or criminologist and so on. Ariko icyo mugomba kumenya nuko kanseri z'ibihaha zirimo ubwoko bubiri bunini, either small cell or non small cell. Babitandukanye kubera iki? So ntabwo bavuze large cells, izindi zose bazikombinye hamwe, nubwo harimo yitwa large cell carcinoma, harimo yitwa adenocarcinoma and squamous cell carcinoma, which on this diagram where they are showing which a proportion of each type of cancer is caused by smoking. Ariko icyo nshaka kugarukaho ni iki, nuko iyo bavuze small cell carcinoma of the lung, muri context yacu bivuze ngo umurwayi afite small cell carcinoma of the lung, it means death. Nta bundi buryo bwo kumuvura buhari, biba bisobanuye ko no gutegereza agapfa, nta kindi kintu. So that's why they categorize these two. So izindi zishobora kuvurwa kandi zigira prognosis yenda kuba nziza, ariko there's the other ones, just they die in a few months or weeks. So therefore, detaining this, we have a non-small cell carcinoma and you have a small cell carcinoma. Of course, mu bihugu byateye imbere bafite imiti immunotherapy ibihenda cyane, hano ntabwo twigira bashobora kuvuza bafite small cell carcinoma, but iyo ubibonye nabyo ubona ko ni ukugerageza, ntabwo ari benshi bakina. So they have a table here that we will not read. Ngo navuga bimwe bya paraneoplastic syndrome. They produce endocrine or nervous system paraneoplastic syndrome, kwa gukora hormone nka ADH, STH and so on. And they are risk factors, either smoker or not. So kanseri yiyongera cyane cyane mu banywa itabi, ariko ku bagore byagaragaye ko adenocarcinoma iri kuzamuka, and this is less associated with smoking. So ku badami nayo irimo izamuka iba nyinshi, nubwo nabo hari na squamous cell carcinoma zizamuka muri bo kubera nabo basigaye banywa itabi cyane uburinganire. So how do you stage it? As any other cancer, the staging, the higher stage means worse prognosis. And mwarabonye muri neoplasia general pathology. So the staging we use is TNM. T refers to the tumor bareba inganite yafasha hagera kuva he kugera he. N refers to nodes or lymph nodes. Are they affected or not? When they are not affected, you put 0. When they are affected, you put 1 or 2 or 3, depending on the numbers of lymph nodes which are involved. And then M, it refers to metastasis. Is it either present or not, or you don't know? When you don't know, you put the X. When you know, then you put 1. When it is not there, you are sure, you put 0. So ikindi twavuga nuko hari tumors zikunda gutera ibindi bibazo nka bita pancreas tumor. This is a tumor which affects the upper lobe, hejuru ku gasongero k'ibihaha, bitaro bigira ingaruka ku kuboko, kubera ko this brachial plexus ibinyura aho ngaho hano hafi y'ibitugu. So bitera ibibazo ukaba wabyitiranya n'ibibazo by'urugungo rwawe ibitugu n'ibindi, kandi ari ikibazo kiracima because it is close to the pancreas tumor. So the staging, so iyo tumaze gukora TNM staging, muzamubona ko akenshi mbere twongera ijambo P iyo tuvuga pathology. When it is a staging based on pathology, put P, and then clinician will put a staging using C. But usually they combine, the clinician will combine pathologist finding and the radiological findings and so on. So akagira stage yanyu. So bitewe na lymph node zafashwe cyangwa zitafashwe, bitewe nuko kimingana naho iri, then at the end tugira stage. Turabona bafite stage 1, stage 2, stage 4. Akenshi indwara zibarirwa kuri stage 4, uretse kidney zigira stage 5. So ni stage, it is here stage 3A, 3B, and stage 4, and stage 1A, 1, 2B, 2B, and 2N. So bitewe n'izi conditions zose ziri aha ngaha. So I think this diagram can help you when you are having a patient. Ntabwo umuntu ategetswe kubiboroka ibi ngibi. What is essential nuko yakweba stage 2, 1 or 2, it is a local disease. When it is 3 and 4, it is advanced disease. What prognosis tugomba kukimenya. Ikindi nuko igihe cyose we have a tumor, you have a cancer patient, you must stage. Then ukajya kuri reference yawe niba ufite akangaka cyangwa ufite ikindi ukakora staging, then oncologist akamenya icyo gukora. So the survival is not good, as I said. So the survival, for example, it is said that overall the survival is between 20, the 5-year survival, I mean. Nukuvuga abantu after diagnosis bamara imyaka 5 bakiriho hagati ya 13 kuri 20, and this is in developed countries. So you understand that in our context is worse. So the small cell carcinoma, you see that the small cell carcinoma, the survival is less than the non-small cell carcinoma, as I was saying. You must keep this in mind. Ibi bituma muri pathology kugira ngo ujye kuba umuntu afite small cell ubanza gutekereza kabiri. Ntabwo ari ibintu uvuga unaniwe and you are not sure, then you ask your colleague. Kubera ko ni nko kuvuga death sentence, no kuvuga ngo umurwayi acira urwo gupfa. Nicyo babivuga. So ni ikintu bagomba kwitondera rero. Ntabwo ari diagnosis tutanga gusa uko yone wihuta, no. Must sit ukatekereza neza ukitegereza ko nta kintu, there is nothing which can contradict what you are about to confirm. So ending in pneumothorax, twavuze ko igihe umwuka winjiye muri pleural cavity, it will be pneumothorax. When it is a fluid, it will be like a blood, it will be hemothorax, and so on. Or pleural effusion when it gets any other fluids. It should not cover pus and so on. So there may other specific terms. So here there are not figures on the right. This is the left, they are on the left here. So ikigaragara iki gihaha cy'ibumoso cyabaye collapsed, as you see it is compressed, kandi ikindi kiri opaque, so ntabwo winjira mu mwuka, ahubwo umwuka wibereye inyuma yacyo muri pleural cavity anga. So urumva utabizi neza ashobora kuvuga ati ibi ni ibihaha koko harimo umwuka, but you combine the history, the clinical findings to imaging findings. So ikibaho ni kirero nuko ya pneumothorax kimwe na emphysema yandi twavugaga, kubera uko ahumetse umwuka winjira hano urinjira winjira muri aha ukarushaho gukompresinga iki gihaha, yasohora umwuka hasohoka usa n'uwari waje muri ariko uyu winjiyemo inyuma nta gusohoka byumvikana. So ibyo bituma uko arushaho guhumeka hano hakomeza kwinjira mu ndi mwinshi. So the consequence nk'uko mubibona ngaha nuko thorax isa naho ibigize thorax birimuka bikajya ku ruhande rutari affected. Bako rwanda ruri affected rwuzuyemo umwuka ugenda usunika bigara. So there is a deviation of the trachea even. Will be deviated towards the healthy side, while the affected side, trachea is ayihunga ndetse na bronchi is sanibijya hin. So this is what is seen on the X-ray. So hari indwara ndatavuze yitwa atelectasis, aho lungs noneho ziba collapsed or alveoli collapsed. It is the opposite. Uzasanga ahubwo trachea iba deviated toward the area which is sick. So atelectasis, the deviation of the trachea will be towards the affected side, while in pneumothorax, the deviation will be towards the healthy side. So the last disease here is in mesothelioma, which is a cancer. Okay, mesothelioma can be benign or malignant. It depends on what histology confirms. It depends on how cells look like. So it can be malignant or benign, but usually they are malignant. So it arises from the cells lining the pleura or lining the peritoneum, pericardium, and so on. So the most of the causes, it is asbestos. Asbestos. So, and you see here that there is a massive mesothelioma that has entrapped or encased the lung. Yeah, so it has encased the lung. So this is what we had to cover. So if you have any questions, you can ask.
Doctor, there is no problem.
So no question.
There is
So-
no question.
So should I ask you my questions, or you are not ready? No answer. So we skip the questions then.
Yes.
Sorry.
Yes, lecturer, let's keep it. We are tired.
Okay.
You are tired, lecture.
Okay. Maybe we will. So have a nice weekend.
Thank you. The same to you.
Thank you, lecture.
Inzobere zisigaye nizo tugiye kuganira. Inzobere konkurude bimeze bite?